Good morning. It's a pleasure to see you all here today. And we're here to celebrate the first anniversary of the Abdul Latif Jameel Institute for Disease and Emergency Analytics, which was founded a year ago, somewhat fortuitously as it turns out, with a donation by Community Jameel, a large philanthropy based in the Middle East. And since then, of course, the COVID epidemic has occurred and we have had to scale up operations faster than we could have ever anticipated. We now have produced a total of some 37 scientific reports, multiple papers, also advised governments around the world and produced planning tools to assist in that. And you'll hear about some of that work today, but also in more general context of understanding what we have learned about COVID, both scientifically, in terms of its epidemiology and the clinical aspects of the disease, in terms of economic and social impacts. And finally, the third session we'll be seeing today will discuss, how do we learn from this pandemic to make more resilient healthcare systems going forward. And so it's a great pleasure, before we get into the meat of this symposium, for me to introduce Dr. Alice Gast, the President of Imperial College, who will have a few remarks to mark this occasion. Alice.
Good morning. It's my pleasure to welcome you to the celebration of the Jameel Institute's first anniversary and this exciting symposium, Shaping the Post-COVID-19 World. It is really hard to believe that only a year has passed since we launched the Abdul Latif Jameel Institute for Disease and Emergency Analytics, JIDEA. It was a memorable day, full of hope and vision. We were rightly celebrating a very powerful new partnership. Imperial College London was combining its amazing academic strength with a world-leading foundation, Community Jameel. On that day, we said, this transformative collaboration will amplify the impact of Imperial's research where it is needed most. Little did we know that the world would so quickly be turned upside down by an emergency of epic proportions. We didn't realize that where it was needed most would be everywhere. As Fady will well remember, we were also celebrating a great honor for another Community Jameel partnership, JPAL, the Poverty Action Laboratory at MIT, whose co-founders were awarded the Nobel Prize in Economics. I'm pleased to have Professor Esther Duflo, co-founder of JPAL, with us today. I join with our Jameel Institute Director, Professor Neil Ferguson, in welcoming her. We also welcome our other distinguished participants, Dame Sally Davies, Dr. Jita Gopinath, Sir Jeremy Farah, Professor Jonathan Haskell, Dr. John Nkenesong, and Professor Peter Smith. Thank you all for making this symposium such a high quality and intensive conversation. The global attention toward the Jameel Institute was inevitable. It just happened more rapidly and urgently than we foresaw. Neil and our co-director Katharina Hauk and their incredible team members have worked night and day to advance understanding of the pandemic and to provide rational advice to governments around the world. Their scientific papers have changed the world. Speed is critical in the beginning of a pandemic, and notably, on the 17th of January, their analysis of the 3 cases outside of China was the clarion call for the world to recognize that there was substantial human-to-human transmission. The following week, Fady and I and several of our colleagues and about 3,000 other people were all packed into crowded rooms to discuss the future in Davos. Imagine if that early human-to-human transmission had made Davos a shaper of the future, a potential superspreader event. 1 year before at Davos 2019, our colleagues spoke about Disease X and presented ideas for a new self-amplifying RNA vaccine and new solvents to stabilize vaccines at room temperature. This work is proceeding at full speed. It is more important than ever. The Jameel Institute's work on chronic and other infectious diseases, their community and government engagement on education and policy, and their training the next generation of public health leaders is also proceeding at pace, despite the disruption to ways of working. I cannot overstate the importance that philanthropy has paid in this work. In addition to the tremendous generosity and support and vision from Community Jameel, we're grateful for the support from many other donors, especially as many research teams pivoted to working on the novel coronavirus. Our new vaccine platform and novel detection technologies would not have advanced without these donations. The whole world is indebted to these generous people. Thanks to Community Jameel and others, we will soon begin construction on our transformative new School of Public Health in the White City campus, where active collaboration across disciplines, sectors, clinical providers will be a reality. There, the Jameel Institute and others will lead the field of public health as a multidisciplinary, data-driven way of working, collaborating with the neighborhood community, governments, and people around the world. Thank you for joining us today.
Thank you, Alice. And I'd just like to add my thanks personally to Community Jameel for their generosity in founding this institute and indeed vision. And I'd like to hand over now to Fady Jameel to say a few remarks on the occasion of this first anniversary.
Thank you very much. And thank you, President Gast, for your kind words and for those inspiring remarks. My lords, ladies and gentlemen, distinguished guests and speakers, I am delighted to join you today on behalf of Community Jameel as we come together to mark this important milestone for the Jameel Institute, the one-year anniversary of the start of its work to address the world's urgent health challenges. To introduce who we are, Community Jameel is an international organization supporting science, technology, and learning to achieve breakthroughs in the field of education, health, and climate resilience. This year marks 75 years of our family tradition of philanthropy. It should have been a year of celebration. Instead, it has been a year of immense difficulty in the world, one that we could not have imagined 12 months ago. Like President Gast, I remember very well the day the Jameel Institute launched last year. I stood in one of the beautiful rooms in the White City campus, next to where the new School of Public Health and the Jameel Institute were being built. It was a moment of possibility. I just heard the exciting news that Asad Duflo, who is speaking today, and Abhijit Banerjee, co-founders of the Abdul Latif Jameel Poverty Action Lab at MIT, JPAL, had been awarded the Nobel Prize in Economics. JPAL and the opening of the Jameel Institute are central to Community Jameel's mission to ensure policy and programs are backed by data and evidence. However, none of us could have anticipated how soon the Jameel Institute would have been at the center of responding to the global pandemic. On behalf of everyone at Community Jameel and far beyond, I would like to thank the Jameel Institute and Imperial College for all their tireless work over the past months to apply the power of data science to this awful virus. President Gast and her team guided the creation of the Jameel Institute and its positioning at the heart of Imperial's COVID-19 response. And under the brilliant leadership of Professor Neil Ferguson, the faculty and staff forged a pivotal role for the Institute. The work demonstrated the team's world-leading capabilities and unique ability to help respond to global health challenges. Above all, they reminded us of the vital role that our global scientific community can play in solving global health challenges using data and evidence. We are deeply honored by our association with the Institute, as it continues to be at the forefront of responding to COVID-19. Looking ahead, we are excited to see the challenges the Jameel Institute will tackle next, from community health and chronic disease to the intersection of climate change and health, an issue that I know the team is working on, part of the project to make recommendations to the G20 this year in Riyadh. To conclude, although this has been a remarkable year for the Jameel Institute, I know the team will match its efforts in the years ahead as they continue to grow in the world leader in evidence-based health policy making. Thank you very much.
Thank you, Fady. And we're now going to our first session, which will be facilitated by Nimalan, who will introduce himself then. Thank you.
Great. Thank you very much, Neil. And let's jump into the first of our panel discussions. First of all, welcome everyone. My name is Arinaminpathy, and it's my real pleasure to facilitate this first panel. So in this discussion, we'll be looking at the lessons learned so far during the COVID-19 pandemic and thinking about what it means for the next few months and years. Now, we had 3 speakers billed for the panel, including Dr. Maria van Kerkhove from the WHO, but unfortunately, Maria is no longer able to join us because of a last-minute urgent matter that came up. But nonetheless, we'll have 2 very prominent speakers today, whom I'll introduce in a moment. But first, the way we'll run this session is to start with very brief presentations from each of our speakers before moving on to a broader moderated discussion with the panel. And I should mention this symposium is being recorded and will be available on the J-IDEA YouTube channel after the event. Now, for all of you who are listening at home or in your office, first of all, welcome. We'd love to have questions from you for the panel as well. So to participate, all you need to do is to look for the icon on the Teams window. It looks like a speech bubble with a question mark inside. So you can click on this and enter questions for the panel, and we'd be delighted to have your participation. And also notice that you can vote for questions that you particularly want to be answered. So let's begin. So I'd like to jump in and introduce our first panelist for today, who is Sir Jeremy Farah. Now, Jeremy is the director of the Wellcome Trust. He's a clinician scientist, and before joining Wellcome, Jeremy was director of the Oxford University Clinical Research Unit in Vietnam for 18 years. He's a fellow of the Academy of Medical Sciences in the UK, the National Academy in the USA, and a fellow of the Royal Society. And Jeremy was knighted in the Queen's 2018 New Year's Honours for services to global health. So, Jeremy, I understand you're only able to join for the first 45 minutes of the panel, but thank you so much for taking time out to join us today. Jeremy, over to you.
Yeah, thanks, Nim, and thanks very much to the Jameel community for supporting this. As Alice said at the start, and coming from the bias of being head of Wellcome, philanthropy has proved to be incredibly important during this, and it's wonderful to see the Jameel community supporting this centre institute so well, and pay tribute to you for doing that. Nim mentioned this at the start, and both Neil and I here are in a slightly uncomfortable position because Maria van Kerkhove, who we've both worked with extensively over the course of the last 9 or 10 months, and I think has been an absolute brilliant spokesperson, scientist, and leader at the WHO, was had to pull out just in the last few minutes because of an urgent thing. This being Neil and I doing it, and I apologise for that. It just wasn't possible, as I understand it, for Maria to join us. So Nim, thank you very much for the introduction. There's obviously a huge amount to reflect on, and I'll try and just summarise that in a few minutes of my own reflections of the last 9 or 10 months. But very like others on this call, I first heard about this on the 31st of December, and I think it was very clear from the 10th, certainly by the 15th and the 20th of January, that this really was going to be an extraordinary event. And a few reflections on that as it's panned through. We can talk about further events during the course of 2020 with the questions and answers. But some of the lessons for me have been public health really matters. And what you have in public health, and when I talk about public health, I mean in its very broadest context. I mean everything from social sciences to mathematics to epidemiology. I think personally clinical medicine and public health have been divorced for too long, and that they actually belong very closely together, but also the One Health and the animal health agenda. I mean, when I talk about public health in its broadest context, public health really matters, and you cannot just turn it on when you need it. You invest in it, and by it I mean people, I mean infrastructure, I mean funding, I mean long-term sustainable institutions and partnerships, and you cannot just turn that on when you need it. If you neglect it over many years in any or all of those aspects, when you do need it, it won't be there for you. The second is that whilst I spent much of my life, the last 20 years certainly, thinking and working in epidemics, is that public health has to be of value and utility day in, day out. If you just set these structures up for emergencies and crisis, the truth is they tend to drift away. They tend to get neglected over time because there are more pressing alternatives. And therefore, I think as you build resilience into the system, a word that will be used a lot through this morning, I'm sure, resilience doesn't mean just having surge capacity. It means that those structures have to be delivering for people all of the time, and that then have the resilience to cope with the additional surge capacity that is needed. And that those public health systems have to be tested. We had the JEE, the Joint Evaluation Exercise for Pandemic Preparedness, and clearly that did not highlight what was really required in crises like this, because those countries that actually did pretty well on that have actually proved to be wanting when it came to the pandemic itself. And to heed warnings. This COVID crisis has not come out of the blue without anybody thinking about it or talking about the possibility of the last 20 years. In my view, since the Nipah outbreak in Malaysia in 1999 through to today, 21 years, we've been given a series of warnings that because of changing ecology, changing climate, changing in human-animal health behaviour, urbanisation and travel, that we had the very features in the 21st century that were going to make epidemics like this more complex and more frequent. And each time we've been through one, there has been reviews, there's been learnings, lessons learned, and then after the crisis ends, that has drifted away again. And many of the very worthy and sensible reforms that have been suggested have not then been put in place as people's attention moves on to the next event. And so if there was ever a moment when we have to really pause and think, what are the real challenges of the 21st century and how will we put in place the systems and structures to both prevent them and then respond to them when they do happen, we will not have learned the lessons from this horrific episode of 2020. And if we think of the challenges of the 21st century, they have some common features. They will almost all be transnational, they'll almost all be trans-regional, and many will be global. And therefore, unless we have the both national and international structures and systems in place, the partnerships established in the inter-crisis periods so that they can respond in a crisis. If we don't have those international structures in place, we will not be able to respond. And the move over the last 5 or 10 years to, I think, systematically and politically undermine many of those structures will do us a great disservice in the years to come. And finally, winding back, Nim, I think that science has been on the front page of all newspapers over the course of the last year, and science itself needs to learn what its role in society is. It needs to bring humility and needs to understand and communicate uncertainty. But science has a critical role to play in society. It's uncomfortable at times, very uncomfortable. But we cannot go back into ivory towers after this. We have to appreciate our role in culture, our role in society, and be prepared to be part of that debate and discussion, again, not just in a crisis, but all. Back to you, Nim.
Wonderful. Thanks so much, Jeremy. It's a really powerful reminder that we can't just turn on public health when we need it, but also for the really pressing need for enduring lessons from this and previous outbreaks and pandemics. So I'm sure these are things we're going to be coming back to discuss in a moment. But before that, perhaps let me introduce Professor Neil Ferguson for his comments as well. So Neil Ferguson is the founding director of the MRC Centre for Global Infectious Disease Analysis, as well as the NIHR Health Protection Research Unit for Modelling and Health Economics, and the Abdul Latif Jameel Institute for Disease and Emergency Analytics at Imperial College London. So Neil's research aims to understand the epidemiological factors shaping infectious disease transmission in human and animal populations. and he informs governments, the European Union, the World Health Organization, and other public health agencies on emerging infections and infectious disease modeling. Neil, over to you.
Thanks, Nim. Thanks, Jeremy. And yes, it's been a remarkable year for the world, and certainly for those of us in the scientific community who've been at the heart of trying to understand this new virus. And I think just building on what Jeremy said, it has been remarkable how the global scientific community has come together in this epidemic. I mean, from right at the start, from work done, critical work done by Chinese scientists, which was very rapidly published, and then globally in terms of both clinical research, epidemiological research, and vaccine development, as we've seen celebrated in the last 2 weeks. It has been, I mean, truly remarkable. What has been perhaps less satisfactory has been the level of, let's say, strategic coherence on the policy side. I think WHO has attempted to do its very best in terms of its role as a normative agency for setting guidelines, but too often the world and individual countries have made policy largely in a vacuum. And it's true, really, particularly across high-income countries, where we see at the current time, whilst there's commonalities to policies adopted in different countries, every government is generating its own set of interventions, and there has not been enough global coordination. And we're going to see this reflected in coming months in terms of inequitable access to vaccines going forward, despite the best efforts of many. In the COVAX initiative, I should highlight as one which Jeremy, Wellcome Trust and CEPI has been involved in, and many countries have donated to, and for the World Health Organization, for getting vaccine to low-income countries, but still it is going to be high-income countries which get the bulk of vaccine in the first few months. So I think it is a matter of kind of many contrasts this year. We've also seen science, as Jeremy alluded, at the forefront and centre of politics. And that means putting scientists such as myself into a position which is not naturally our natural place to be. And we've seen science in some cases rather politicised. I think the bulk of the scientific community resisted that, but coming back to Jeremy's point about what is the role of science and scientists in a crisis, I strongly believe it is to give the best scientific advice on what we know about a new threat, and it might be a virus, it might be climate change, and say these are the policy options available to us. And then it is for policymakers to choose between those options, understanding the potential consequences of the choices and understanding the uncertainties. What I'm much less comfortable with, and what we have seen a little of, is on both sides of, let's say, the divide, the apparent divide, it's not really a divide within science, is scientists saying, you know, my government needs to do this. And that isn't really a scientific viewpoint, it is a personal and political viewpoint, and the two things get mixed up. And maybe we can explore that in this session a little more. But I'll hand over to Nim now, and we can start the discussion proper.
Great. Well, thank you so much, Neil. Actually, that's a great point to start our discussion. Both you and Jeremy brought up the points about the role of scientists and science in these very important decisions that are being made for public health and for society. I just wondered if both of you could reflect a bit more on, how should I put it, well, perhaps what advice you might give to young scientists who might be filling your role in the next public health emergency that may happen, let's say, 10, 15 years from now, in terms of how best they might work together with decision makers. Perhaps Jeremy first.
Yeah. Yeah, it's a good question, Nim. Keep as broad-minded and as willing to work across boundaries and interfaces as you possibly can. There's none of us that are capable of individually covering all of the areas that you need in our day-to-day work out of a crisis, and of course in a crisis, because because the breadth of disciplines you need to bring together is so broad. Neil and I come from very, very different disciplines and backgrounds, and yet over many years we've forged an ability to work together and with other colleagues from very different disciplines. And I think I worry that the scientific endeavour is pushing people to be too narrow too early. The way that our funding bodies, including my own, works is to encourage a great depth, and perhaps doesn't encourage sufficient lateral horizontal thinking, and makes it harder to switch, not switch disciplines, but work in other disciplines. And I think that is to all of our detriment, because in the end, it is the bringing together of different perspectives and disciplines which will be the most important in addressing the challenges of our time, whether that from all the disciplines that are obvious to everybody. And I think that is something we're going to have to work on. And I think particularly true in the UK, where, of course, from high school onwards, most people become very specialised very early. And I have to say, I'm still a great believer in the baccalaureate approach, and I'm a great believer in the good bits of the US undergraduate program, which keeps people broader minded for longer, I think. And one of my great mentors from my early days as a junior doctor taught me that it's at the interfaces that you'll have the most exciting careers and opportunities. Having said all of that, the other positive of COVID is that I think this must surely inspire a whole new generation of young people to come into science, because the opportunities in science over the next 20 or 30 years are going to be absolutely extraordinary. And we've seen in this crisis how science has moved forward so incredibly rapidly and in such exciting ways that has to be a career you'd want to be part of.
Fantastic. Thanks, Jeremy. And Neil, your thoughts?
Yes, I suppose I've been fortunate. I moved out of theoretical physics a very long time ago, and it's rare for theoretical physicists to be involved in policy advice. I think epidemiology, actually, and it's true of also disciplines like climate science, are intrinsically interdisciplinary, and there is opportunity for people working in those disciplines, going into scientific research in those disciplines, to really engage with the policy debate from any career stage. And I think lessons, and I certainly from my first postdoc have been involved in scientific advice to government. I think one of the benefits of engaging early, and there are many opportunities, particularly in the UK, but in other countries as well, for doing that, is that they are different mindsets and there are different priorities in between the policy and the scientific community. And so building relationships and understanding those differences of mindset and what is key to policy advice at an early stage helps later in terms of being able to focus, particularly in a crisis, on what's important. Royal Society has a number of opportunities for scientists who, for instance, shadow MPs, and there are other such kind of interning opportunities, and I encourage, anybody who's interested to apply to those. I think the Academy of Medical Sciences has something similar. So I think this crisis has highlighted how science and policy, particularly in a crisis, are so intimately linked, and sometimes uncomfortably, but actually most of the time in a very productive way, even when, clearly there are more things than just science going into policy. But my experience in this pandemic is working with civil servants, principally, and working with Patrick Vallance and Chris Whitty has been generally a very satisfying and productive experience. Yes, sometimes policy doesn't necessarily reflect quite what we might hope it would, but that is for also understandable reasons. I think get in there early, put yourself forward, and be prepared to have maybe a different sort of scientific career which balances getting those good papers out with other forms of quite rewarding scientific activity.
Fantastic. Thank you both. We're getting some really great questions coming in on the interaction between science, decision-making and society. But what I'm going to suggest is perhaps let's come back to this topic just to make sure that we have enough time to discuss the science of COVID-19 as well. But coming back to COVID-19 for the moment. So Jeremy, you mentioned starting to hear some news towards the end of 2019 about this novel pneumonia that was circulating in Wuhan. And of course, a lot has happened from then till now. And I'd be interested in both of your views on what you think have been perhaps the most important things that we've learned about the virus and about its control in the last 11 months. And perhaps this time Neil first, and then Jeremy.
I think paradoxically we now know more about this virus, and it's certainly its epidemiology, and I'll talk about its epidemiology, than we do about almost any virus. The sheer intensity of research which has gone on in a very short time period has given us, I mean, using the very latest, both in terms of testing and other technologies, data analytics, surveillance systems, data science, has given us a completely unrivaled view into the epidemiology of this, compared with even, for instance, influenza, which is probably the best studied respiratory virus out there. So I think the key things about this virus we understood really quite early. I mean, I would say by the beginning of March, which is how transmissible it was, namely more transmissible than flu, a reproduction number of about 3. How lethal it was, which in countries like the UK and US and much of Western Europe with quite elderly populations, was about 1% of people who got infected dying, though that thankfully now has reduced down to improvements in treatment. And finally, that basically, and we have a more nuanced understanding of this, but basically the entire population was susceptible. Since then, and then that really informed policy making. I mean, that once we saw epidemics doubling every 3 to 5 days, with that sort of healthcare burden, 2 to 3% of people being infected, requiring hospitalization, that inevitably meant that even the best equipped health system would be overwhelmed. And that really was the key driver of policy. Modelling put to one side, it was that basic epidemiological analysis which drove policy making around the world. I think since then we have a much more nuanced understanding, not perfect by any means, many uncertainties around transmission. The fact that it's highly heterogeneous, almost certainly probably 10% of those people infected account for 90% of transmission, and a lot of people, for reasons we don't fully understand, do not really cause much in the way of secondary cases, apart from perhaps in the household context. We know that households are key drivers of transmission, but also other contexts where people mingle indoors for extended periods of time. We know much more nuance about severity, both clinical at-risk groups, but also the fact that basically your risk of dying from this disease increases exponentially with your age. Quite a remarkable, it's called a log linear straight line. And we know more than we used to about what's the minimum set of measures required at a population level to maintain control over this disease. But as you can see from the current time, when we're in the middle of a kind of second, more mild, let's say, or less stringent lockdown than the first, but a second lockdown in England, and much of Europe is in the same position, we realise that we have very little in the way of wiggle room if we want to keep schools open and keep most workplaces functioning, to have much in the way, frankly, of a social life. That we don't need that many contacts, additional contacts in society to occur between people to move from a state where the virus is decreasing in transmission to one where it's increasing. And that leaves us in a difficult position for the next few months. But I think the other remarkable breakthroughs have been on the kind of vaccinology and immunology side, where we now have a handful, and it will soon be more than that, a handful of vaccines which have even got through initial phase 3 trials and demonstrating significant in many cases very high efficacy. We have a better understanding of the immunology of this virus overall. So, I mean, remarkable results in trying to, dissect the immune response, the relative role of antibodies versus T cells, the fact that maybe children have some pre-existing immunity which might explain the milder disease we see in those age groups. So, I mean, it's been remarkable, but clearly much more to yet understand.
Great, thanks, Neil. A nice summary of remarkable progress in the last less than a year now. But yeah, Jeremy, what are your thoughts?
Yeah, I agree with what Neil just said. The only additional comment I would make is that in events like this, and this has been true in, I think, every epidemic, frankly, of the last 20 years, the information you have early may be uncertain, but it's enough to act on. And Neil said the beginning of March there, I would actually push him a little bit further. I would say that at the end of January, we knew enough to have acted, and we waited. We waited out of uncertainty. We wanted to be more certain than we needed to be. But by the end of January, we knew that this was able to transmit asymptomatically, that it caused a nasty clinical syndrome and significant number of people were dying, that healthcare workers were getting sick and distant family members were getting sick when people moved from Wuhan to Sichuan, that this was going out of China into other parts of, certainly at that stage, Southeast Asia, that we had no diagnostics, no treatment, and no vaccines. To me, at the time, and this is not in retrospect from either of us, I think that was enough to have acted then in ways that we delayed. And in a fast-moving epidemic, if you delay, even by days, certainly by weeks, then you're playing catch-up. And I think the lesson for me in that is cope with the uncertainty, go with the information you have whilst gathering new information, and don't get behind the curve.
Very important message. Thank you, Jeremy. And Neil, I just wanted to pick up on one of the really important characteristic features that you mentioned, which is heterogeneity. And this relates, so one of the audience members have asked this question about heterogeneity, not just between people, but also geographically. So the question is from an anonymous participant, are we now able to better explain the heterogeneous effect that SARS-CoV-2 has had in different countries and regions? Do we have a better sense of what's driving this heterogeneity in global spread?
Well, I'll do quickly because then Neil can come in. But actually, I'd put the question around the other way. I think this has been less heterogeneous than the question implies. Actually, the responses have been very heterogeneous, and that has led to very, very different outcomes in the epidemic. But the features of this, I think, have been incredibly consistent across the world, and therefore the lessons one can learn from other countries have been even more important than their differences. And I think some of the nationalistic exceptionalism, we're different to other countries, we can't learn from them, I think has been at the root of many of the problems, frankly.
I mean, I agree. I mean, in my opening remarks, that was my main point, that I think countries could have learned from each other in a policy context much more than necessarily happened. And in particular, the United Kingdom and the United States, which were the more exceptional countries in terms of most of Europe locked down in a matter of 2 or 3 days on 16th, 17th, 18th of March. And you see that the countries which locked down at an earlier stage of their epidemic saw much lower mortality overall. But actually, if you go dig into the data, they were seeing the same infection fatality ratio, plus or minus a little bit. It's just the transmission. I mean, moving to a global context, you see much more variability really in surveillance in the reporting of deaths. So you also do have variation because of demography. I mean, in countries in sub-Saharan Africa where half the population is under the age of 20, you're inevitably going to be seeing much less mortality as a fraction of population. There's also apparently a hint of slower spread, and that's probably again down to the fact that younger people are less susceptible, whilst they can get infected and they can transmit, they're less able to than older people, and so that slightly slows spread there. I think so. And then there are many countries where we only have a very limited handle on the true burden of mortality and disease this pandemic has yet caused, and it will take in those countries probably months or years to disentangle that. I'll just give two examples: South Africa, for instance, and Mexico, both of which have done their very best to test as many people as possible, but in both of those countries, the excess mortality, they have death registration systems, those countries have seen is twice the reported COVID mortality, and really quite significant. So I agree with Jeremy. I mean, we can understand the heterogeneity as much as anything down to the kind of policy response with a bit of demography layered on top.
So coming back to this, because it strikes me as a very important issue, at least for future preparedness. In our third panel this afternoon, we'll be talking a little bit more about future preparedness. But I wanted to come back to the point you raised, Jeremy, about having waited for too long, the sense of exceptionalism and so on. How confident do you feel that the lessons learned from this pandemic are enduring lessons at the decision-making level? And if perhaps they're not as enduring as we'd hope, what do we need to do to ensure they are?
Well, I think a lot of the responsibility of that lies with us, and by us I mean everybody on this call and the broader community. If we allow this to go the way of previous epidemics, which have been mostly regional or national, and the lessons learned, the beautiful reports written after, for instance, Ebola, West Africa in 2016, which had a lot of very worthy things in them, which we would all agree with, but ultimately were not put in place. Then I think that's the responsibility of the generation that lives through COVID to not walk away at the end of this, move on to other priorities and forget this. This is in our hands. We're not just passive observers of what happens. We actually can change the way things happen, and I think that's the responsibility that we have to go through. The other thing, just in thinking about the interventions, Neil mentioned, the coming of technologies as well and innovations, and I think there's also a facile argument coming, often put forward, that there are no magic silver bullets in this, but that is not the same as saying you don't need some bullets. And what we can't do is be left vulnerable and exposed in the future without the capacity for knowing what the social interventions are. Restrictions in this case have been so influential, but also and not shy away from the fact that we also need financial and fiscal incentives and interventions that matter and sustained over the long term. But we do also need the fruits of biomedical science to deliver the diagnostics, the surveillance, the health systems, the oxygen, the PPE, of course, but also the treatment and the vaccines. Because if you don't have that collection of bullets, then you're left with effectively 19th century interventions. And we've got to do better than that in the 21st century. And whilst I'm not suggesting for a second that a vaccine is a magic bullet that will answer everything, it will be a hugely important part of how we both prevent this reverberating pandemic of now, but also how we address future potential epidemics and pandemics of the future.
Great.
I would say, I think the single biggest thing to avoid again, and frankly it was a mistake in 2009 and we got away with it because the mortality was low, was too much of a focus on fairly nominal surveillance of, for instance, travellers coming into the country on the basis of let's wait and see what happens, and not standing up systematic surveillance within our countries. And that wasn't just a mistake of the UK. was a mistake of, frankly, all the countries across Europe which were worse affected. It's why Italy had far more transmission than they ever expected, and they had to lock down very immediately. It's why Spain and France got overtaken by the virus. Because basically when countries did switch on testing in hospitals in Europe in March, they suddenly realized they had a huge amount of transmission within their countries. And we should never let that happen again. If there's any sense of a virus which is spreading beyond country borders, which is transmissible from person to person, we should be looking for it in our countries, given how globally connected every European country is.
Great, thank you both. This actually relates to a question from one of our audience members. Locan C asks, what might be the positive spillover effects of the acceleration and development processes of vaccines and therapeutics to address COVID-19 for addressing existing endemic diseases and novel infectious diseases with epidemic potential?
So this is where I feel you have to be an optimist, and you have to make sure that when you do go through something as horrific as 2020, that there are some silver linings that come from it. And I think Neil's comment earlier that the scientific community globally, that goes across academia, it goes across nations, goes across industry, government funding, philanthropic funding, and other, is a bright spot of 2020 we need to keep hold of, and we need to learn that you can disrupt the way we do things when you have to, and you don't need to sacrifice things like safety and process, but you can do things quicker. You can do things in parallel rather than in sequence. You can do things at risk rather than waiting to be sure about everything. But that will need, if we're going to do that, and we're going to do that for both endemic and epidemic issues, we're going to need the public sector, and include philanthropy in that, we're going to need the public sector to think again about the risk sharing and the benefit sharing with industry, academia, public and private funding in a way that we've perhaps outsourced too much to allow all the risks to be held within the private sector. This is ultimately public health. And governments, multilateral organisations and philanthropy, I think, is going to have to rethink how we sustainably finance this work in the future, and we don't leave it all outside the public sector in terms of making sure we have the interventions that the public health needs.
Just on a pure science front, I think the potential of RNA-based vaccines been highlighted for the last few years, but often industry is quite risk averse at taking on new technologies, and I think this has really jump-started what is a very exciting new vaccine technology, which I think, answering your question of how do we get vaccines out faster, scale up manufacturing faster, and reduce their cost eventually, I think these technologies are going to revolutionize vaccines in the next few years.
And just on that, Nim, we absolutely, and Neil mentioned it earlier, COVAX and CEPI and things, the ACT Accelerator, we have to make sure that we build a genuine commitment to equity and access into that from the start, not as an afterthought months or years later. We have to learn the lessons of the HIV epidemic of the 1990s, COVID of 2020, and say, how can we ensure a more equitable and fair access to these essential global common goods in the future?
Yes, thank you. So those are some really great observations, and also brings us very nicely onto the questions of vaccines, which we are having a few questions coming in on that. I think it's astonishing to think that I think the genetic sequence is published in mid-January of this year, around that time. And now, less than a year later, we're seeing interim results of 3 vaccine candidates showing very promising results. So at least the development pipeline has gone amazingly. But I just wondered what you folks thought about the next steps in terms of, hopefully once these vaccines reach licensing and are then made available for use, what the main challenges might be in the global rollout of these vaccines. So we've had questions, for example, about public trust in vaccination, but also about who it is who's designing the logistics, for example, for the distribution of these vaccines. Jeremy, any reflections?
Yeah, just very quickly. The science is not done on the vaccines yet. There's a huge amount of science that still needs to be done, of understanding immune response, understanding whether in the AstraZeneca Oxford one, the low dose to start with, followed by a standard dose, is actually more immunogenic and more protective. There's a huge amount about the longevity of the responses, how these work in different communities, populations, demographics. So the science is not done. And remember, these are only first generation vaccines. It's inevitable there will be improved vaccines in the future. But the science will continue, and what needs to sort of transition, if you like, is the logistics, the rollout, the trust, the communication, understanding and learning lessons of vaccine rollouts in other countries, polio in northern Nigeria, polio in Afghanistan, measles, meningitis, spell-tax. So huge amount to learn from countries that have been rolling out vaccine campaigns over the last 10, 20 years, where much of Europe, North America has not actually done that in the past. And to me, that comes down to, yes, very professional logistics, but it also comes down to local ownership of rollout, trusted individuals working across sectors, from faith groups to sports clubs to local radio, social media, etc., so that people have access to transparent data. They know that the vaccines are safe, and they know they're effective, and they can trust the regulators to be politically independent and do their job to ensure these vaccines are safe. Those are, to me, trusted local delivery of vaccines on the background of really professional logistics is the best way of rolling these things out in the most equitable and fair way.
I'd say for low-income countries, the rollout of COVID vaccines is an opportunity to strengthen, universal health coverage and basic vaccine delivery systems, and which have been getting stronger in the last 10, 20 years anyhow. I don't think the resources exist to put in a completely dedicated logistics system just for COVID. I think that is unfortunately what a lot of, well, certainly the UK, US, and a lot of European countries are going to have to do, because we're just not as used to doing, large-scale population mass vaccination. In the UK context, plans are well advanced on how that's going to occur. I would say the delivery of the vaccine is going to cost probably more than the actual vaccine doses themselves, which is often the case.
Yeah, and organisations like Gavi, UNICEF, the Red Cross, and others are going to be absolutely critically important in, for instance, Gavi-eligible countries. I do have major concerns about those countries and sub-regional, within-country variation and inequalities. And then those countries in the middle tier who are not necessarily Gavi eligible, but which will undoubtedly be challenged in terms of rolling out campaigns such as this, and we need to find a way to support them, not just critically the Gavi eligible countries.
Yes, it's a really important point that just having the vaccine doesn't necessarily mean we have the vaccine coverage that we need. But incidentally, I'd like to, I saw a headline recently, I forget exactly where it was, but this was relating to saying the end of COVID-19 is in sight because of the advent of these vaccines. And I wondered what you made of that. First, Jeremy, to start.
I don't think there is an end to COVID-19. I think my view is unless something unexpected happens, which it could, of course, could disappear. I don't think that's going to happen. I think we're now talking about the emergence of what is going to become an endemic human infection for years to come. And there will always be susceptible people in communities that are either because they're born and they've not developed immunity yet, or because they lose that immunity, or they don't get vaccinated, or whatever. So I don't think this is going to disappear. And of course, one of the concerns with the news of the mink mink farms in Denmark is not necessarily mink farms, but whether there is now or could be an established animal reservoir for this in the future of a virus that is relatively promiscuous, can come across from the animal sector to begin with, somewhere in China, into the human population, and now can go back into another animal population and be sustained in an animal community. So I think this is with us to stay. And like many other infections, we need to learn both to deal with it, have the interventions that matter, but also go about life in a normal way. And I hope in 2021 we'll start to see that with the interventions that are coming online.
Neil?
I don't really have anything to add. Yes, I mean, I can't imagine any way this will be eliminated from the human population. So we're going to be living with this virus as an endemic virus and its descendants, let's say, as it evolves for the indefinite future. I would say that, again, coming back to the kind of innovative vaccine technology and the remarkable high efficacy of the RNA vaccines, I think this is an opportunity to again rethink and maybe redouble efforts towards more effective flu vaccines, and indeed more effective, think about vaccines against other respiratory viruses, which, whilst they don't cause enormous mortality themselves, do contribute to mortality and morbidity, particularly in association with, say, pneumococcal and other bacterial infections. And so I think, again, what we've done this year may well have rewards in the future in terms of, better controlling respiratory infections overall.
Yeah, I share that view, Nim, and I think to work in the field of vaccinology directly, you've got to be a lifelong dedicated optimist, because the last few years have been a struggle. We've been trying to make vaccines for HIV, for tuberculosis, for malaria, really difficult diseases to. I think in the part that's given us a sort of slightly too pessimistic approach, and I think one of the things for me for COVID is actually to demonstrate with modern technologies, disruptive approaches, including the RNA approaches, that actually it is possible to address some of these. And what I would hope it would do is this would be a renaissance of vaccinology generally, will have implications way, way, way beyond COVID.
Mm-hmm. Really important points. Thank you. And Jeremy, I realize you may need to head off soon, but before you do, I'd like to take the opportunity for maybe a provocative question. And this is relating to the control measures, lockdowns, stay-at-home orders, movement restrictions, whatever you want to call them. Obviously, they've had a very important role in the global response against COVID-19, and have certainly had an important impact in terms of reducing transmission, but obviously, as we know, have exerted a lot of societal and economic disruption. Now, Katrina and her panel will be discussing a bit more about the societal and welfare implications in the next panel. But I just wanted to take the opportunity for a quick retrospective and ask you, in your opinion, were the lockdowns worth it, given the amount of disruption that happened?
Yeah, I'm going to have to answer this in less than 30 seconds, but and it'd be nice to come back to more longer-term discussion. But frankly, I think they were the only options at the time, and actually in some jurisdictions remain the only options at the time, because otherwise the consequences, you've got to remember, public health always prevents things. That's the aim of public health, and therefore, but the trajectory this epidemic was under in many countries would have led to overwhelming health systems, including in all countries, the richest countries as well. And frankly, I think with the interventions we had available through 2020 until right at the end now with vaccines and treatments, lockdowns, unfortunately, were the only option in order to reduce transmission, reduce pressure on the NHS, and actually save lives. And uncomfortable as they were for all of us, and very inequitably distributed across countries and within countries, I think, frankly, they were the only options during much of 2020, yes. But thank you very much for it. I'm going to have to sign off now and leave you in capable hands. But just again, pay tribute to the work of Imperial colleagues throughout this. It's been remarkable, uncomfortable at times, but the impact of Imperial science globally and nationally has been absolutely pivotal to the response to COVID-19. And again, just thank the Jameel community for sponsoring and supporting this critical global centre at Imperial, and thanks to philanthropy for doing that. So I'll sign off, Neil. Very good to see you. And
Much
Neil,
appreciated. Thank you, Jeremy.
see you soon.
Thank you. Fantastic. So we have perhaps a few minutes remaining, Neil, and if you don't mind, maybe we can think about some of the questions that are coming through from the audience members. By the way, thank you to the audience members for all the questions that you sent in. Please do keep them coming in. Some really great questions there. So Neil, perhaps we can have a look at some of these before maybe pivoting to some future prospects right at the end of the Q&A. So there's some questions around vaccination, just following on from our discussion just now. And Jeremy mentioned the need for a very strong scientific basis and evidence basis transparently to show people about the safety of these vaccines. So there's a question from an anonymous participant asking about communicating this not just scientifically, but also encouraging public trust in the vaccine despite the speed of development. For example, those individuals who'd say, "I'll have the vaccine, but don't want to be in the early cohorts." What are your thoughts on improving confidence in the vaccine or vaccines?
Well, I mean, I think the key issue is about transparency. Beyond anything else, and I would agree with Jeremy that the science is not currently for all of the vaccines in its early stages. So in the next few weeks, we will see the full regulatory dossiers which are going to regulators for emergency approval of those vaccines. And I think looking at very carefully at what the adverse events are, and all vaccines have some side effects, whether it's just a sore arm or a headache for a few hours, but communicating clearly that this is what's expected. And then communicating the kind of benefit-risk ratio. We have a virus which, particularly in the elderly, has real risks associated with it, and vaccines which can dramatically reduce that risk. I think beyond that, beyond the kind of communication of the science, I think there is a role for governments and the scientific community to counter disinformation. And there is a lot of disinformation out there about vaccines. And it can be easy for us as scientists to dismiss as being, I mean, frankly, Looney Tune anti-vaxxers. But people do listen to it. And there is the challenge of kind of social media echo chambers. And we need to go actively out there and engage. And engage with the broader society, to engage with influencers and otherwise, so that and other similar people, so that we are, with evidence behind us, advocating something which will benefit the whole community. And the thing about vaccines is they benefit both the individual who takes them, but if enough of the population take them, they benefit the community as a whole, including people who are, for instance, unable to take the vaccine.
Very important. Thank you. Excuse me. And so we discussed earlier about the things that we had learned over the last year about COVID, but just looking ahead now, perhaps to the next 6 months, what do you think are the most important uncertainties that need to be addressed in our response to COVID-19? So
I think two important aspects, or maybe three important aspects. One is what sort of social distancing and other measures are we going to need to keep in place as we head really into the heart of winter and through to next spring? How can we best, and I think other sessions will talk about this, how can we best balance the need to maintain control over the virus, but allow economic and social activity to continue to the extent that it can? I think the second is, just we've been talking about, is exactly, well, both planning the logistics of vaccine rollout, but understanding these vaccines and getting more scientific data on the vaccines. As Jeremy said, we don't understand the longevity of the immune response generated, and that will be important. It may be quite short-lived. And so if people lose immunity, whether natural or vaccine-induced, say, for instance, which is quite feasible over the period of a year or 18 months, then we'll need to plan to have repeat vaccination. We also need to understand heterogeneity in people's response to vaccines. Often we see frail elderly people having a less good response to, for instance, influenza vaccine. It's less effective in those people than in the broader population. If that turns out to be the case for COVID, then it'll put more impetus and priority behind trying to get very high levels of coverage across the broad population to drive down transmission so as to protect those who are most vulnerable. I think the third is there's lots of discussion of long COVID, but there are, as well as, of course, long-term economic effects, there are going to be long-term health effects of this pandemic, which we still don't understand well enough, but will be important in terms of understanding the real burden of disease this pandemic has caused, and in terms of understanding how best to help those people affected.
Great, thank you. We've spoken quite a bit about vaccination, but of course we know that testing is also a very important part of the response, and certainly will likely be an important part of the response until a vaccine becomes available, and perhaps even after. Could you speak a bit to how much we've learned about what it takes to make an effective testing program, and to what extent we can rely on the lessons that we've learned so far as a stopgap until vaccination becomes available?
So as you say, I mean, testing is, test and trace has been the mantra often repeated around the world for many months now. Testing on its own is not an intervention, though, as people who've been involved in screening programs for decades for diseases can tell you. It's what you do with the test result and how that informs policy. So clearly test and trace where contacts are isolated, where cases are isolated promptly is key. For many countries, that has been very difficult. Testing capacity has been very, very limited. And I would say the new testing technologies, lateral flow assays, whilst they're not perfect, less sensitive in some ways than PCR, still for much of the world offers a real opportunity for much cheaper, easier to use and easier to roll out testing at scale. Those technologies have been considered, for instance, in countries like the UK for doing mass population testing. There I'm more hesitant at the likely benefits of that. Slovakia has done it and has driven down transmission to a degree, but at enormous cost. Where I see those sort of rapid tests being most useful, though, is in protecting vulnerable populations. So without doubt, if we could test care home workers twice a week with these new lateral flow assay rapid tests, and where I see the real potential benefit of those is less so in mass population testing. It would have some effect, but be hugely expensive. I think the real benefit is in testing people most vulnerable and most at risk and protecting those. So, for instance, testing care home workers twice a week. And there, the lateral flow assays have the huge advantage of getting test results back in minutes and not in days. And so you can really, if somebody's positive, a care home worker is positive, they don't go into work, you can even test visitors in the same way and prevent infection getting into care homes in the way it did in March and April. Similarly, healthcare workers, particularly those in the front line, preventing them accidentally infecting patients in hospitals. Potential use in very high prevalence hotspots to drive down transmission, but not so much transmission, drive down prevalence of infection, but that relies on then the people who get the test results isolating. And often I think the challenge at the moment is that it is very difficult for many, particularly poorest in our society, to actually isolate and carry on living. I mean, they depend on going out for wages. And so we need solutions to that, for that sort of large-scale testing to be a viable strategy.
Great, thank you. Again, thank you to the audience members for the questions. I see a number of questions about the future pandemic response and what this means about future preparedness. But what I'm going to suggest is perhaps we could leave that for Tim Hallett's session in the third session this afternoon. But very briefly, Neil, one of the interesting questions that come through have been about virus mutation. Which is, what do we know about virus mutation as particular, and if I could paraphrase the question perhaps its potential implications on immunity. I mean, the question's in terms of vaccines, but I guess more broadly we could think about immunity.
So, I mean, work by Eric Voltz and colleagues in the centre here and in the Institute has really informed some of the understanding of some of the dominant mutations, and clearly there have been mutations which have spread in the virus population, which may well affect transmissibility, but probably don't affect either lethality or what's called antigenicity, which is, you know, what the immune system sees. So as yet, we have seen a number of mutations arise which affect various proteins in the virus, but none of them appear to be changing the likely effectiveness of vaccines. But something we certainly need to pay attention to and to monitor over time. And because, like, if it does happen, then we may need to generate new vaccines really quite quickly.
Great. Thank
we're
you.
out of time.
I think we have another minute.
Okay.
If
I can squeeze.
If that's okay. Yeah, I just wanted to close with a with a reflective question for you, which is basically looking now over the next 6 months, perhaps 1 year to 5 years. How do you envisage the transition to a new normal after all of these disruptions and changes to society?
I think it will vary a lot from place to place, but if we're talking about the UK or much of Europe, I think we will see a very difficult 2 or 3 months ahead as we go through winter. But as we get substantial numbers of people vaccinated, remember you need 2 doses spaced basically a month apart before you get immunity. So, I mean, from your first dose to getting immunity is typically about 4, 5, 6 weeks. So even we start vaccinating now, we have to go that much further. So in reality, I mean, we will have a difficult few months with similar sorts of measures in place as we have now through to the end of March, I would say, in much of Europe. At that point, both because of seasonality, but also because a lot of the most vulnerable people will hopefully then be protected, we will be able to relax social distancing measures and current restrictions quite noticeably. I'm certainly hoping so. I'm looking forward to going on holiday myself in at least April or maybe May. I don't think it'll be complete by that point. It will take then many months to get truly back to normal as we roll out vaccine across the whole population. And unfortunately, for many countries of the world where they have lower supplies of vaccines, it will take longer to truly get back to normal. And as Jeremy said, one of the key priorities, I think, for those of us who are more fortunate, living in higher income countries at that point, will be how can we accelerate vaccine deployment in those countries?
Fantastic. Great. Well, thanks very much, Neil. I've very much enjoyed that discussion, and I hope all of our participants have too. But many thanks to both you and Jeremy. And so that brings us to the end of our first panel discussion, and we're now going to go into our first 10-minute break of the symposium. But just to mention for all participants, please remain online and don't log off, because what we'll be doing now is to show a short video of interviews with the director and the principal investigators for J-IDEA, talking about their vision for the Institute. And the event will resume following the video. So see you all back here momentarily. Thank you.
Hello, I'm delighted to be joined by Professor Neil Ferguson, Director of the Abdul Latif Jameel Institute for Disease and Emergency Analytics. Neil, can you tell us a little bit about yourself and your research?
I'm an infectious disease epidemiologist, and I really focus on mathematical epidemiology. That's understanding the transmission of infectious diseases in particular. Most of my career, I've worked on what are called emerging infections, either diseases which are new to human or animal populations. And we, of course, are living through at the moment the largest pandemic of such a disease the world has seen for 100 years, namely COVID-19, which J-IDEA, the acronym for the Abdul Latif Jameel Institute for Disease and Emergency Analytics, has done a lot of work on.
Thank you. And can you tell us a little bit about J-IDEA?
So the founding of J-IDEA really built on our experience in the last 10, 15 years in responding to emerging infectious disease epidemics with partners. And we wanted to go further and do what we were doing in a better, more coherent, integrated way. So we have 3 pillars to J-IDEA. One is the application of novel data analytics to really enabling better, more efficient and more rapid responses to health emergencies around the world. The second is in helping to reinforce health systems around the world. The biggest predictor of how well a country responds to a health crisis is the strength of their health system, but also health systems underpin population health more generally. We can only do this in partnerships. So the third pillar is about building better partnerships with public health agencies like the World Health Organization, but also with individual governments around the world and with other academic institutions.
I'm delighted to be joined by Dr. Katerina Huck, Deputy Director of the Abdul Latif Jameel Institute for Disease and Emergency Analytics and a reader in health economics. An important theme for JIDEA is health systems. What are we doing for health systems or within health systems for COVID?
Yes, obviously at the moment we are in emergency response mode, and a large part of our work is, of course, epidemiological modeling. But JIDEA's remit is broader, very much about how to make countries resilient to deal with the crisis that they are facing. So we are actively working on strengthening health systems. So, for example, in order to prepare countries who are potentially facing a second wave, we are analyzing data. How can we treat emergency COVID patients while also keeping up services for non-COVID patients, keeping up essential cancer care and elective surgery?
Thank you. And lastly, can you tell us your vision for JIDEA?
Well, following on, really, it's all about emergency preparedness going forward, working with our partners to make countries more resilient to dealing with crises, not only on infectious disease outbreaks, but going beyond that to other crisis situations that have grave public health impacts, such as armed conflict, environmental disaster, but then also more long-standing crises related to climate change and to the rise in non-communicable diseases. So this is really all about health system strengthening for us. It's about building horizontal programs that are disease cross-cutting. It starts with a strong disease surveillance, testing capacity, lab capacity, a fast first response, and a strong network of primary care facilities. And then above all, strong governance in countries. And we are really looking forward to supporting our partners.
I'm delighted to be joined by Professor Tim Hallett, Research Lead for the Abdul Latif Jameel Institute for Disease and Emergency Analytics and a Professor in Global Health. Tim, can you tell us about your vision for JIDEA?
Yeah, I think I'd like to see it really achieve two main things. One, I think we can build really strong partnerships with those in positions in low-income countries who are wrestling with these difficult questions. I think there's a real opportunity for capability building and mutual learning through those partnerships, and I really look forward to that. Secondly, I think that we can really bring a lot of the sort of analytical and data and modeling techniques that we use in different areas to bear on this crucial issue of health system strengthening, and really make the case of what it means and how to do it and evaluate it as well. I think that's sort of the next frontier, and I think JIDEA can really make a contribution.
I'm delighted to be joined by Professor Edward Gregg, a research lead for the Abdul Latif Jameel Institute for Disease and Emergency Analytics and chair in diabetes and cardiovascular disease epidemiology. Ed, can you tell us a little bit about your vision for JIDEA?
Sure, I think JIDEA actually brings an incredible opportunity to, with its focus on cutting edge methods, capacity development with a focus on emergencies and health system strengthening, to actually look at how infections interact with chronic conditions. We traditionally treat those issues as sort of separate, with separate people working on those areas, but I think the COVID-19 pandemic has reminded us that these actually interact, and the effects of emergencies on people who already have conditions is enormous. And we can do a lot to actually improve our understanding of the epidemiology, monitor populations. We can use new cutting edge modeling approaches to understand what approaches are going to work best to to reduce disease and suffering that occurs in these sorts of emergencies.
I'm delighted to be joined by Professor Calypso Chorkidou, research lead at the Abdul Latif Jameel Institute for Disease and Emergency Analytics and Professor of Practice in Global Health at Imperial College. Calypso, can you tell us a little bit about your vision for JIDEA?
I think JIDEA is a really exciting development, bringing together really interesting and important and timely streams of work, and people doing work in these fields globally acknowledged. I think that this is the time for JIDEA to boost its impact and sort of expand its footprint through emphasizing even further the importance of building capacity, as we've seen with the COVID crisis. It's so important that countries, all countries, but certainly also resource-constrained countries, have capacities in terms of people, in terms of data, and in terms of institutions and systems to understand, track, preempt, but also address outbreaks such as the one we're living through today.
Delighted to be joined by Professor Majid Azati, research lead at the Abdul Latif Jameel Institute for Disease and Emergency Analytics and Professor of Global Environmental Health at Imperial College London. Majid, can you tell us about your vision for JIDEA?
Sure. I mean, at the most basic level, I hope JIDEA within a matter of months and years will have really large and positive impact on health of people, especially on the health of people who most need it, the poor, the marginalized groups. And I obviously hope that, given the purpose of the Institute, that we do this by bringing people together from different parts of the School of Public Health, from different disciplines, and I certainly hope from different stages of their career, especially our early career colleagues, to use a wide variety of data and the methods that we have all used, but not often together, to answer the big questions in global health and in public health with a lot of impact. So a place of exchanging and generating ideas around data and around methodology for better health.
I'm delighted to be joined by Professor Helen Ward, research lead at the Abdul Latif Jameel Institute for Disease and Emergency Analytics and clinical professor of public health at Imperial College London. Helen, can you tell us a little bit about your vision for JIDEA?
I think JIDEA has got a crucial role to play in bringing together the many disciplines that you need to respond and direct and support the response to emergencies and health challenges. We collect data in all kinds of different ways, and I'm involved, for example, in the current COVID-19 outbreak. I'm involved in a very, very large set of studies in England to collect data on people who are out there, whether they've got the infection, whether they've had infection, which is shown in antibodies. Now, we're doing this by working with the public so that they collect the samples themselves, and in fact, for the antibodies, they do their own tests. That is really important because it's an efficient way of collecting data, but it also opens up our conversations and engagement with members of the public, which I think is very critical to any outbreak response. What we collect then is fed into the kind of statistical and mathematical modelling that helps us to understand how we've got to the position we're in, and then start to inform the response going forward. So I think that drawing together of engagement of the public with actually doing empirical research is a bit of the centre that is my passion, if you like, to bring those things together.
Thank you, and thank you for your time today.
You're welcome, thank you.
So welcome everyone to the second session on the economic and social impacts of the pandemic. I'm Katrina Haug, Deputy Director of JIDEA and a reader in health economics. First, a few housekeeping rules. We would really love to hear from you during the sessions. You can post your questions in the Q&A box. You can remain anonymous if you want. You can also vote for the questions you want to be answered by the panel. I will try to post the most voted for questions to our distinguished speakers today. The symposium is being recorded and will be posted on the JIDEA YouTube channel. There will be 3 short presentations from each speaker, followed by a panel discussion. And there will be a 10-minute break after this session, so please don't log off, but remain online for our session on pandemic preparedness. Now, just to place our session in context, throughout history, we saw that there were devastating pandemics that were catastrophic in their health impact. But there have also been powerful change makers and actually redistributed income and reduced inequality in the end. The bubonic plague in the 14th century contributed to an end of feudalism, and the 1918 flu pandemic was followed by a period of great social change and economic optimism, the Roaring Twenties. Now, what we see, of course, now is very different, in that the adverse social and economic impacts are concentrated among those that are already most disadvantaged. We see that blue-collar workers or those in informal employment face the greatest threat to both their health and their livelihoods. So it is my pleasure that in this session we are joined by 3 distinguished economists to discuss the short, mid and long-term economic and social impacts of COVID, to discuss how they can be mitigated, and then lastly to inform the research agenda of JIDR for the next years with the generous support of Community Jameel. So it is my pleasure to introduce our first panel speaker. It is Professor Jonathan Haskell. He's external member of the Monetary Policy Committee at the Bank of England. He's also Professor of Economics at Imperial College Business School. And he's an expert in productivity, innovation, intangible investment and growth. He has widely published across his field of expertise and is author of a book, Capitalism Without Capital. So Jonathan, the floor, or rather the channel, is yours.
Katerina, thank you very much indeed, and good afternoon, ladies and gentlemen. Thank you for coming along to this session. I've got 6 slides, so I'll try to be very quick, talking through some of the economic effects and challenges. So if we could go over to the next slide, please. I'm going to try to ask in this 2 questions. The first question is it health or is it GDP? And a lot of the discussion, it seems to me, seems to be about that left-hand graph I hope you can see on the screen. Namely, if I plot on the axes the loss in GDP on the vertical against the mortality on the horizontal, a lot of people will say we can either be in the top left or we can be in the bottom right. If we shut down the economy, that's up there on the top left, then we'll save lots of lives, but we'll get a very large GDP loss, or we can be on the bottom right there. If we keep the economy open, we might get a lot of we might be able to not have so much GDP loss, but we would have many deaths. So let's examine the data on that. And the second thing I'm going to do, if you could click on the next button, thank you very much, is about the vaccine. So thanks to the fantastic science and all the ideas that Neil Ferguson was talking about in the earlier session just now, it looks like, as The Economist magazine puts it, suddenly a little bit of light at the end of the tunnel. So will we bounce back if the vaccine is effective? So if we could go to the next slide, I'm going to start by looking at the very first questions. The first question here, is it health or GDP? And here's some work by Fernandez, Villaverde and Jones, which plots that graph, which is up there on the top right, just to remind you about what the hypothesized shape looks like, and sees what actually happens in the data. So if you go over to the left, you can see that you've got areas like San Francisco, so these are cities, which have had a big loss in activity, but rather few deaths. So that supports the idea that maybe one is in the top left of the diagram. But on the other hand, you've got New York City, where there have been a high mortality rate and a high loss of GDP as well. So that seems to go against that. Likewise, if we go over to the right, and we plot countries, the vertical axis here is again an index not quite of GDP, but an index of reduced activity. You see the points are a bit all over the place. There seem to be some countries on the top right there with a high mortality rate and a high loss of GDP. The United Kingdom is one of those. I'm speaking to you from the UK now, so that's obviously of concern to us. Yet there are also some countries in the bottom left there as well. So it does not seem to be that kind of trade-off between health and GDP. Rather, it seems to be a situation in which we can have an outcome where we've got relatively little health loss and little GDP loss. That's the sort of bottom left, or we seem to be up on the top right. And so the question for economics, at least, and again, there was a lot of discussion at the interesting session just now about the balance between the various losses and the epidemiological, on the epidemiological side, the economic losses. The question for economics is to try to sort of get some understanding of that. So if we could kindly go to the next slide. Let me say a word about that in the UK. So apologies, everybody, for this rather busy slide. Let me try and walk you through this slide with a little bit of the UK situation. So the pink line is an index where here at the Bank of England we've developed on social spending. So you could think of this as spending at restaurants and out in the pub and all that kind of thing. And you can see that that gradually went up over time it starts in July this year. It went up in September, but then it started to come down again. Right. The blue line is from an Office of National Statistics survey, which asks people, how comfortable are you when you go and eat out at restaurants? And you can see that was a rising line, that blue line, and then that blue line started to fall again. So guess what? It's not a 99.999% correlation, but it does look like there is a strongish correlation between the spending and the confidence that people have of eating out, at least at restaurants. And what you can see is that people's confidence fell more or less at the end of August, the beginning of September. And the dotted line gives you a little bit of an insight into that, because the trouble is the infection rate started to take off at that time. So why are we going through all of this? Here's the point, that even without a lockdown, the lockdowns, the pub curfew and the pubs reopening are those vertical lines there. Here's the lesson, even without a lockdown, there was still a dip in social spending as people worried about the infection rate. So it's simply not the case that the lockdown is going to dictate whether people are going to spend a lot and whether GDP is going to be high or low. The lockdown is itself an outcome from the fact of the worry about the growing infection rate. The key is the infection rate. And therefore, if we have a situation in which we have very high infection rate, in this case with the infection rate going up very strongly, then we're going to get a loss in GDP because people are going to worry about going out, irrespective of whether we have a lockdown or not. If we could go on to the last slide, thank you. Let me come to this second question about how fast we will recover and to what extent. And apologies, I just have to walk you through this right-hand diagram. That dotted line is a diagram of UK GDP before the pre-COVID. So sorry, that's the green line just there. And you can see that at the Bank of England, this is a bank forecast, we thought the economy would grow. The red line is the line of actual GDP, which falls very strongly and then goes back up again and recovers. And the blue line is the financial crisis. So what do we get from that? The first thing you see is from the financial crisis, it took a very long time for GDP to recover. The second thing you see is that our forecast is the economy will come back, but there'll be a gap between the red line and the blue line. And that gap refers, the source of that gap is the scarring from COVID. The other feature that we haven't worked out quite yet is these other structural shifts like working from home. So the changes in the economy, which will come about as COVID, even if the vaccine comes, will have these long-term scarring effects. I'll do one more slide if I may, and this is my final slide, which just restates the conclusion. Is it health or GDP? And I've said there seems to be not a trade-off because of people's behaviour. And my last point, if the vaccine is effective, will we bounce back? And as Jeff said, we've got a long way to go, and these scarring effects might hold us back. Catherine, I'll stop there. Thanks very much indeed.
Thank you, Jonathan. That certainly gives us a lot to discuss later. Before we do that, I want to introduce our second speaker, which is Professor Esther Duflo. She's Abdul Latif Jameel Professor of Poverty Alleviation and Development Economics at MIT. She's also co-founder and co-director of the Abdul Latif Jameel Poverty Action Lab, JPAL. She won the Nobel Prize in Economics for her extraordinary contributions to economics and numerous other prizes. And in her research, she seeks to understand the economic lives of the poor with the aim to help design and evaluate social policies. Esther, please. The floor is yours.
Thank you very much. Can you hear me well?
Yes.
Thank you and happy anniversary to J-IDEA, who is our little brother at JPAL. So we are very happy to welcome you into the family and see you do your first steps with such gusto. And we are looking forward to seeing many years of great work. Regarding the topic today, how to mitigate the social and economic impact of the pandemic, I just have a few points I would like to highlight, which both have to do with the impact of the pandemic in the poor countries, in developing countries where I do most of my work, and where JPAL Global also does most of its work. So the first point to emphasize is that from the strict COVID perspective, for developing country, in many ways, the pandemic has been less bad than was feared at the beginning. It's not to say that it was good, but it was less bad than it was feared at the beginning. The infection rates in Africa have never really reached anywhere near the level that were feared early on. And in a country like India, for example, there have been very many cases, but the mortality rate has been much lower than what it has been in richer countries, partly because the population is much younger, maybe for other reasons as well. But at the beginning, since we had no idea how this virus was going to behave, there was the concern that the population, which is, for example, not very well nourished or suffers from a lot of comorbidities like diabetes, for example, would be particularly at risk. And the fact is, although the pandemic has struck, it's not been the unvarnished disaster than many of us feared early on. However, and partly because there was this fear at the beginning, which were emphasized by many people, including GIDEA and including us to some extent, developing governments in developing countries very quickly went into very aggressive measures of containment, even as they had almost no cases at the time. And they were piloting in the dark, so it's not that they had necessarily much choice about what to do. But the point is that India went into a very strict lockdown with almost no warning to the population when there was almost no COVID cases in India. And then it relaxed the lockdown precisely when the cases started to come in. So from the strict point of view of the control of the epidemic, the lockdown was terribly timed. And from the point of view of people's lives, these lockdowns in developing countries have had consequences which are often much, much worse than what they have been in rich countries. So the data that Jonathan showed were all for rich countries. I don't have the equivalent for poor countries, but for example, Gita's department at the IMF estimates a loss of GDP for India of 24%. And in all of these countries, especially, for example, in Africa, the instrument that was available to the richer country of starting to borrow trillions of dollars to prop up their economy and avoid a snowballing effect of the initial crisis into a massive Keynesian demand crisis wasn't available. Even in a country like India, early in the pandemic, they just didn't want to do anything but for fear of worsening their credit rating. And when they started spending some money, it was spent in a very different way than in the richer countries. In the richer countries, there was immediately an effort to support the weakest people, and not just the firms, but also make sure that employees could continue to be paid. So in Europe, it was done with a furlough that was paid by the government. In the US, it was done with generous unemployment insurance. And that was the money to do that wasn't really available in the poor countries, even though institutions like the IMF, like the World Bank, said that had powerful statement that the most powerful, the best thing to do now would be to have massive universal cash transfer to tide people over during the crisis, it wasn't done. And it's not that it wasn't done because government didn't think it was a good idea. It wasn't done, or it wasn't done in a large scale because they had no money. And one thing that I think we will have as a member of the rich countries and the rich world, the OECD, to answer for in future generation is, what were we doing at the time where we were spending trillions of dollars to support our own economies, which I think is perfectly legitimate and we should totally have done. Wasn't it possible to find some rounding error to go and help out some of the poorest countries in the world that were in a way like living through a crisis that was, at least they had not much anything to do with it than us, and at worst they were in a sense they got it because it emerged from much richer economies. So I think so very early in the pandemic, Abhijit Banerjee and I called for a Marshall Plan for poor countries that would be two-pronged, which is one on the health side and one on the to help prop out health system to deal with a possible influx of COVID cases, and two on the economic side, in particular to help countries finance universal non-contributory cash transfer, but it didn't happen. So we still have a chance now. I think it didn't happen in partly because the rich countries were so obsessed with their own crisis, maybe it's not surprising. But now that we have some hope at the end of the tunnel with a possible vaccine, we have a kind of a second chance to do this. And perhaps with better leadership in some of the powerful countries in the world, that becomes possible. Today, we have the possibility of a vaccine. There are two things that we need to really get our heads together and come and to the help of the poor countries in a systematic and large-scale way. The first one, of course, is making sure that vaccine is available in the poor countries, and the second is to now start this famous Marshall Plan. After all, the Marshall Plan happened after the war in Europe, so I think it can also happen after the COVID crisis in the poor world, and would help accelerating the recovery, which otherwise I think would be much, much more sluggish in the poor countries than it has been in the rich countries. And let me conclude by saying that this is not just for economics, this is also for health. I'll give you just one example. So to date, to my knowledge, 1.4 million people died of COVID, which is an enormous number. However, I want to put that in the context that every year, 2 million children die of vaccine preventable diseases in normal years. And in addition, during the COVID crisis, we have had a collapse in the normal immunization services. So there is going to be an even bigger number of people, of kids who are not immunized for this vaccine that we had for a long time. And so solving these issues at the same time as we're starting about the logistics of a COVID vaccine is essential, and it is only going to happen if developing countries avoid going into massive crisis, which is going to require large coordinated action from the poor world as a one-time intervention. Thank you.
Many thanks, Esther. That gives us a lot to talk about later on. Before we do that, we have Dr. Geeta Gopinath, who is the Economic Counselor and Director of the Research Department at the International Monetary Fund. Dr. Gopinath is an expert in international finance and macroeconomics. She has published widely on exchange rates, trade and investment, international financial crises, monetary policy, debt, and emerging market crisis, so is well placed to answer some of the questions that were posed by our previous two panelists. Geeta, please, the floor is yours.
Thank you, and from my side too, congratulations, happy anniversary on the 1 year of J IDEA. I guess you can't think of a more memorable way to start an institute. I mean, this past year has been incredibly remarkable for all of us all around, and many of us in the IMF, for sure, we've turned to GIDEA for knowledge and guidance, and trying to understand how this pandemic will affect lives, and through that affect livelihoods. In terms of the social and economic impact of the pandemic and how to mitigate it, I'll just make a few quick points. The way we think about this pandemic is in 3 phases. The first phase is the early phase, which was what we saw happening around the world, particularly in the first half of this year, when the reaction was very strict lockdowns, when the virus's spread is uncontrolled to some extent, and you're trying to bring down the rates of transmission, and you put countries into a lockdown. Then there is a second phase, which is when you have the transmission rate somewhat under control, you've flattened the curve to some extent, and then you've had the reopening that has happened, which happened in the summer and sometime early into the fall, depending upon the countries that you're looking at. Now, of course, with the reopening, you obviously know that there can be a resurgence of cases. We've seen that in parts of the world, so it's not a linear progression. You can go between phase 1 and phase 2, back and forth. But you have that phase when you are reopening, and there's a different set of policies for that period of time. And then there is the third and hopefully final phase when you have the pandemic, the health crisis is over, which now looks even more likely given the news on the vaccine front. It will take time, but we are maybe at the beginning of the end of the health crisis. And so the pandemic is over, but we have all the legacies that follow from the first 2 phases and scarring that follows from the first 2 phases. And then there are policies that have to address that too. So just stepping back and thinking about how countries have been impacted in this crisis, I would say there are about 4 factors that help kind of give you a sense of how countries how badly they've been affected. So the first, of course, is the strength of the pandemic, the severity of the pandemic in your economy, and the measures you've taken to mitigate that impact. The second is the sectoral composition of your economy, which means that if you're a country that depends very heavily on tourism, that depends very heavily on the kind of hospitality sector, high contact intensive sectors, or if you're an oil exporter, those economies are being hit particularly hard because this pandemic this crisis very clearly affects some sectors much more than it affects others. A third set of factors, what we call, pre-existing conditions of the economy, which is, did you enter this crisis with a healthy economy, or did you enter with high levels of debt and weakening growth? And that matters a lot for the policies that you can put in place and the impact of this crisis. And then the last, of course, is how much of policy have you been able to deploy? As Esther said, the world as a whole has deployed $12 trillion in fiscal stimulus or fiscal support measures to deal with this crisis. But if you look at the distribution of that across countries, it's overwhelmingly in advanced economies. So advanced economies have spent about 20% of their GDP in fiscal measures. Emerging markets have spent 6% of their GDP in these fiscal support measures, and low-income countries have spent 2%. So you're going from a very strict gradation in terms of the spending that different countries have been able to do to deal with this crisis. In terms of the best, we still are, these are still early days in terms of understanding which policies work the best, and this is going to be part of the research agenda going forward. But there are clearly some lessons to be learned. So in the first phase of the crisis, when you had lockdowns, and even in the second phase, when you have more limited lockdowns, it is very important to provide income support to people who are directly impacted by those lockdowns and to firms that are directly impacted by those lockdowns. And we know that countries that have been able to provide income support measures have been able to recover much faster than the countries that have not been able to do that for lack of, say, fiscal space in some cases. The second thing is you want to prevent kind of excessive job destruction, because if you are going to end up with a lot of firms shutting down, it takes a while to bring that back up. And so you want to prevent that from happening. So again, measures that provide lifelines to firms too, so that they can stay, and especially in the targeted sectors that have been most impacted by this crisis, you want to support them so that you can go over this hurdle of the pandemic and come out at the end. So even if you're not viable during the pandemic, you're viable after it, and you want to be able to preserve those firms so that those jobs still exist when you open back up. Of course, number one, which I should have said at the beginning, was the spending on the health front, and that was absolutely at the top in terms of making sure that you had the right amount of hospital care, the right amount of medical care that could be provided, but also more generally, and I think this is something we've learned, that it's a combination of factors that can help you bring down transmission, and it's not just the lockdown, but it is ensuring that people do wear masks and contact tracing and testing. Those are all those measures is the complement of all those measures that have been most effective in parts of the world in dealing with the pandemic. Now, coming out of this pandemic, what we are going to inherit, one is that this pandemic has been quite unfair, and this is something that Esther mentioned, which is that you have low-skilled workers, low-income households who are getting particularly hard hit. You have countries that have lower income, even if they're not hit as much with the pandemic directly, that are getting very hard hit. Distance learning works in very few parts of the world and doesn't work much in most places or parts of the world, which means there's going to be a generation of students who basically have had a big hit to their human capital, and that's is going to be an important legacy of this crisis. Women have been harder hit than men. Many of them are responsible for childcare. Many of them are the ones who work in personal care sectors. So we've seen bigger increases in unemployment among this group. So there's been a rise in inequality, and for the first time since 1990, we have a projected increase in extreme poverty. 90 million projected to increase enter extreme poverty just in 2020, and the number grows over time. So despite all the 12 trillion that's been deployed and all the considerable central bank support that's been played, these are the outcomes, and this will have to be dealt with going forward. And of course, one can go on for a very long time, but I don't have that much time, so I'm going to just make a couple of points of what needs to be done going forward. But before I do that, I think the question is, all the policy I said, you might say, well, that sounds great, but if you're a country that doesn't have the finances for it, how exactly are you going to do it? And this is a very important issue. So there are countries for which you will need to provide concessional financing and also in the form of grants and just outright aid. We've been providing that for about 76 countries, but I agree with Esther that a lot more needs to be done. And many of these economies are already have too high levels of debt, are in debt stress. So debt relief, in some cases debt restructuring, just to make their debt sustainable is going to be incredibly important. There's no halfway path there. And coming out of this crisis, I think the world has to be one where you are addressing this growing inequality. And I worry about it because this crisis has triggered a move to greater automation. And we know that automation was one of the reasons why you had a hollowing out of the poorest, especially the middle class in some parts of the world, but including just lower skilled workers not making much money. And obviously that doesn't mean that technology is bad and automation is bad, but it's just saying that the policies have to complement it to ensure that you don't have a worsening of inequality. And lastly, it's absolutely clear that we need to address long-standing issues when it comes to mitigating climate change, because this is not going to be the last natural crisis. There's going to be many more that come from it. countries would have to put in place social safety nets. That's the lesson that's been learned from this crisis. Pandemic preparedness, of course, is incredibly important, and fiscal policy will need to remain, and including international support to the low-income countries of the world. Let me stop with that.
Thank you, Gita. That was fascinating and certainly a very ambitious research agenda. So it makes me slightly daunted about what we as academics can do to support you. So my question is really to first Jonathan and then the other panelists. What you had to make decisions under extreme uncertainty. Is the modeling that you have and that you will need, is that up to scratch? What kind of research do you need in order to help countries come out of this shock? Jonathan first.
Yeah, thanks, Katerina. It's a great question. And maybe let me just take a little step back for the non-economists who are watching this. I think one of the things that economists are fascinated by is the incredible coordination in the economy, right? If I walk down to buy some flowers in the UK, lots of flowers come from Kenya, thousands of miles away. I've never met a Kenyan farmer. I've never met, the farm workers who harvest the flowers, yet by an amazing system, the flowers are present, in my shop when I walk down the road. And then on Valentine's Day, there are lots and lots of flowers which are available as well. So the thing that economists spend lots of their times scratching their heads about is how does this sort of miracle of coordination work? And when we think about the effect of COVID and the pandemic, one way of thinking about that is to say that there's been a gigantic shock to the system, as both Gita and Esther were just explaining so nicely. There's been a huge shock to the system. So does the system kind of rebound again? Is it somehow or other, is it like Valentine's Day, where there are lots more flowers which are provided, when people need more flowers? Or does the system somehow or other get stuck? And I think to answer your question, Katerina, what kind of research did policymakers want to know is, in some ways, it's an age-old question, starting from Keynes, which is, faced with these monumental disturbances, in this case an enormous disturbance and shock to the economy, will the system come back again? Will it restore itself? What are the kinds of policies that are required to support it? And we know quite a lot about that, it seems to me, and Gita just talked about that in terms of social insurance for people who, at times of great anxiety, obviously want to have insurance. So, we know some aspects of that. Maybe we know a little bit less about how in the modern economy and an economy with artificial intelligence, in an economy with growing digitalization, how the sort of future will pan out in terms of what sort of support and employment there might be, especially for low-skilled workers. So it's understanding the response to very big shocks and understanding some of those structural changes. I think I'd put a couple of those at least high on my list.
Thank you, Jonathan. So Esther, what do you think is our role as researchers and academics to support this ambitious agenda?
First of all, I think it's good to recall what we do know. There are things we do know which have not really made their way as much as I would like in the policy sphere. Gita ended saying that it's really essential that we that countries around the world put in place a more effective social protection system. And indeed, this is something that in a sense, if the pipes for social protection had been in place, if there was a system of payment to household available, either via bank accounts or via electronic money on people's cell phone, etc., then it would have been easier to activate at the time of the crisis, and this is something we need to have ready for the future. And one of the things, but I think beyond that, beyond the logistic aspect of it, which is essential, there is also the sort of social acceptability part of it. And one of the problems with our social welfare system, which we've seen in full display during the COVID era, is that they are built to exclude. The big worry is that we don't want to include people, we don't want to include too many people. We really don't want to spend money on undeserving poor or on people who are not actually that poor. But during the COVID crisis, the most important was to actually reach as fast as possible as many people as possible as we could. And the big danger was to not include enough people. And the reason we have those systems built on exclusion is that there is this very old age concerns that too much aid would make people lazy, and that if we are too generous in the social system, people would stop working. And in fact, one thing that I think research has demonstrated now over the last 10 years, even 20 years, quite decisively, is that there is no evidence that a more generous social safety net makes people lazy. So, for example, starting with Latin America, but a little bit around the world, there are now unconditional cash transfers. They actually are conditional, but they are not conditional on working. They are conditional on education behavior or health behavior. And so one concern could have been that people who are beneficiary from this income stop working. And in fact, that's not at all what we see. People who get this money are just as likely to work as people who don't. And that has been shown in one randomized control trial after the other. And yet this idea that receiving social transfers don't make people lazy, that has not percolated the system. For example, in the US, when very quickly in the pandemic, they had a very generous compensation for unemployed workers, $600 a week, there was immediately a worry that people would stop working. And in fact, there has been about at least a half dozen studies on this program, which has shown that there was absolutely no impact of this program on labor supply, that people were just as people who had a chance to have a job were so delighted to keep it that they were certainly not going to let it go in order to collect this generous unemployment benefit. And yet you had, the senators and the Wall Street Journal still concluding that this can't be true, they have to be wrong, and we shouldn't have too generous social transfer. And one thing that I think we can learn from this pandemic that is going to be greatly helpful in the exercise we need to get on for the future to redesign our social protection system in a way that's more respectful, more inclusive, and take into account the dignity of the people who are helped, is this piece of knowledge. I think we had it before, but it had not percolated in the public consciousness. A shock like COVID, where suddenly everybody found themselves at the receiving end of aid, not everybody, but a lot of people, is a chance to make that message percolate among policymakers. And that's going to be a very useful input in redesigning a social protection system that are inclusive and efficient and respectful of dignity.
Thank you, Esther. So Gita, my question to you is then following on from the points that Esther raised. What do you think is the role of the IMF in supporting this kind of revamp of social security systems?
So, I mean, just, feeding into something that was said earlier about how this crisis was so unique compared to anything else we had dealt with. I don't think I knew a single economist who knew what the SIR model was. And in I think January of this year, and I think all of us now, thankfully, it's a mathematical model, and we love working with those kinds of equations. So, we've been building models to try and understand this In terms of what the IMF can do, I mean, the IMF is an institution that provides it's kind of more macro support, so it's not like we go into granular details. But what we have done is in this crisis provided emergency financing to 76 countries. And what does that mean? That means that usually, typically, IMF programs come up with conditionalities, but this is one of those cases where it was clear that it was absolutely important to get money into the hands of these countries very quickly so that they could spend on their healthcare, so that they could provide money to the most vulnerable. So this was really unconditional money that was given, with of course some monitoring to make sure that countries are actually spending it on helping their people. So this is the one big, I would say, shift that came about in this crisis, unlike in previous crises where they typically programs and there are, you spend a lot of time trying to figure out what the exact program should be for a country to become, come back to health. The second thing we have done, and this is also a big shift from the past, and this has happened over time, was the IMF, people often say is that the IMF stands for it's mostly fiscal, which is IMF, right? And the critique used to be in the past that the IMF just came in and said, well, unfortunately, you're spending too much and you have to cut down spending. And often that could have been done in ways that was very harmful to low-income households or poorer households. Right now, this is not just now, but over the last decade, if you see the programs that the IMF has done going into countries, we actually have conditionalities which say often that you need to increase social spending at the same time that you're cutting down, you're trying to control the size of your budget deficit, the amount that you're borrowing, if you're trying to bring that down. But you have to protect the vulnerable, and in many cases, we've actually said you need to actually spend more than you've done. So this is clearly a very important piece of IMF advice and IMF conditionalities. When we provide surveillance to countries, which is we give countries some sort of a report card on how their economies are doing, we also report on what's happening with inequality, what's happening with poverty, and the issues that they need to do to address it. So, completely, while we're not the World Bank in the sense that we're not like on the ground doing kind of granular projects, we're certainly not JPAL, addressing poverty issues at the granular level. But in terms of our macro advice, we've shifted from saying blanket, bring down spending or raise revenues, but being much more specific about make sure that you're protecting the most vulnerable in society.
Thank you, Ida. Yeah. So I guess it's a good thing that now economists know what an SRR model is, and epidemiologists know more about supply chains and the complexities of an economy. Now let's move on to a point that was raised in our discussion forum by an anonymous audience member, and also a point that Jonathan raised. So I want to pose this question to you, which is, during the pandemic, we've often heard the choice between health and economics. Now, how do we correct this misconception that there is this trade-off? This is the question posed by the audience. However, I would say also maybe slightly provocatively, clearly countries such as Taiwan and New Zealand and South Korea, who were extremely successful in fighting the pandemic, had quite a resistance to overcome with their tourism industry, who greatly suffered from the more stringent quarantine interventions that they imposed. So how can you answer this question about that? How can you resolve this?
Yeah, thanks, Katerina, and thanks for the question, the person who sent that in. Look, there are obviously lots of different factors which are going to decide this, but I think the most important thing is to bear in mind the sort of behavioral response that individuals quite reasonably have when they worry that there's a very large amount of infection. If there is perceived to be little infection, then of course people are going to go to the pub and do all those social activities, which then feed through to boosting GDP. And if they worry that there is going to be infection, then that's going to go into the reverse. So what's driving this is the fear of infection. Now, the lockdown and so on then comes as the infection rate rises and falls. Now, what that means is we are potentially, without a vaccine, in a pretty bad place if all that happens is that we lock down, it drives the infection rate down, then we release the economy, but it drives the infection rate back up again. And that endless cycling is a very bad place to be. And I think the hope for the vaccine, the hope that the vaccine gives us is very important. So that's one part of the question. The second part of the question goes back to what Geeta Gopinath was saying, and the various points that she was making, with which I strongly agree, about the kind of the elements of an economy which determine how well or badly an economy does when an economic shock comes, which, as well as the types of expectations that I was just talking about, are things like, you know, the fraction of the economy involved in tourism, you know, what the economy has done to prevent health, and the sort of the pre-existing condition of the economy in terms of debt and so forth. So it's a complicated picture, and one has to sort of stitch all of these things together. But I think that's the way to think about it. It isn't sort of unidirectional between lockdown equals bad amounts of bad outcomes for GDP. It's the various elements that hopefully I tried to talk about, and that, as I say, that Geeta talked about as well.
Thank you. Geeta, do you want to comment on these points that Jonathan just raised, particularly on the health-wealth trade-off?
Yes, actually, we did analytical work on this. Our October World Economic Outlook has an analytical chapter where we looked at this question of what was the impact of, was it lockdowns versus voluntary social distancing that led to the drop in economic activity? Now, it's a hard question, and it's hard to find smoking gun evidence for a bunch of reasons. But I think the best analysis that we have shows that for the world as a whole, it was around 50-50, which was 50% was just the independent effect of lockdowns, while 50% was just the fact that even if the lockdown was not in place, people would choose not to go out and engage in economic activity because of the fear of getting infected. And that share tilted more towards the lockdown in case of emerging markets and low-income countries, and it tilted more towards voluntary distancing in the case of advanced economies. But both factors played an important role. But I just want to step back and say about, I agree that the vaccine is hugely important and is, like I said, the beginning of the end of this health crisis. But there are countries in the world that are functioning with almost no restrictions in economic activity, and at the same time being able to keep the pandemic well controlled. An example, of course, is China, where it's an example of no trade-off, where you have very low numbers in terms of cases and in terms of people who are getting affected by it and death rates. And at the same time, it's the economy that's projected to grow, the one large economy of the world that's projected to actually have positive growth in 2020. Then there are other parts of the world, like in Latin America, where again, there's no trade-off, but it's a bad outcome, where you both have a large number of cases and mortality, and at the same time, the economy is being badly hit. So, I mean, the truth is that there are ways to live with this pandemic where you can have both the good outcomes of having fewer infections and good, in terms of economic activity, even in the absence of a permanent medical solution like the vaccine would be. But the truth is, countries have used that very, very differently, and they've not followed the same strategies. One of for instance, the conclusions of our analytical work was that if you're going to put lockdowns, you have to do that earlier. You want to do it at the beginning when cases are going up. It's just not going to be that effective when you already have a large number of cases out there. But I think this is among the lessons we learned for the future. I think this is it. This is one of those lessons. The way I like to think about it is, when we had the global financial crisis, I think the one big lesson we learned was to make sure that the banking systems, the financial system, was well capitalized. And thank God for that. We had Basel III. This time around, despite having the worst recession since the Great Depression in terms of economic outcomes, we don't have a financial crisis. And that's thanks to the lessons that we learned. This crisis will teach us the next time around that there's going to be a pandemic, that we're just much better prepared. And by the way, if I may just make one ask in terms of knowing more, I wish we knew more on the epidemiology, actually, frankly speaking. I've been in calls with epidemiologists since, I think, February up until now. And I think because of lack of data, or the lack of sufficient surveys, there's still all these questions about why is it that the case rates are so low in low-income countries? Why is it that in India, the recovery rates are much higher, the death rates are so much lower? If we knew that, if we had more information on that, we could be so much better at dealing with the pandemic. And so I hope we can get much better information on the epidemiology of this. Since this is the idea, I thought I should bring this up.
Yes, So that will be certainly on our research agenda, Gita, but clearly it's a very difficult question to answer because there are so many factors at play, as you said. Esther, do you want to comment on this issue of the health-wealth trade-off?
No, I think it made the most important point, which is you have to step back a little bit. Like I think it makes very little sense to look at these things, on the month-to-month basis. The point is that having a pandemic around really sucks, like for health and for the economy. There is no doubt. And then if you can control it, that's better. So, and the danger is to look at the very short term, because this is kind of the mistake that some places in the US have done early in the pandemic, of not doing any effort to control the epidemic in order to protect the economy. But then, of course, once the epidemic caught up with them, that was not good for their economy either. It's just that we're seeing that a little bit over a slightly longer time period. So I think in reality, there is no trade-off. And I also started to emphasize there is also no trade-off on the other end, which is if the economic outcomes are really terrible, then health outcome will follow. Not just through COVID, but through other afflictions, for example, via increase in malaria cases for Africa, or childhood diseases.
Yes. Thank you. So we are nearly at the end of our session, and we have a slightly more uplifting question asked by Emma Edwards. And Emma is asking, do you think that there will be any beneficial impacts resulting from COVID-19? So Jonathan, maybe I can start with you. Do you think that there will be, in the mid to long term, anything good coming out of this crisis?
I guess, Katerina, for some sectors, but only for some, there might be increased working from home, which people might enjoy, the flexibility and so forth, although the majority of firms say that they aren't going to go in that direction, interestingly, but that might be an effect. I guess the second thing, which both Esther and Gita have talked about, is I wonder if there might be a change in people's attitudes to support from the state. The fact that the state has stepped in and support in many countries, or not all, and supported people, quite rightly. I wonder if that would change people's attitudes towards social insurance and the kinds of things that Esther was talking about. It's very speculative. I'm not a psychologist, but a lot more people have had a lot more contact, as it were, with that sort of dimension of state support, and I wonder if that might change people's views. Thanks.
Thank you, Jonathan. So Gita, to you, Jonathan's question, do you think it will change people's attitudes?
Well, I mean, in terms of the silver lining, I think it's made completely stuck that countries that had universal healthcare, that had strong social safety nets, that had, put in place digital forms of transferring money to households. All of them were able to handle this crisis better. And I think that will be a lesson that will persist into the future. I can see that I hope that there will be a shift towards much more, widespread, universal healthcare, social security, social safety nets, and a shift to digital infrastructure. By the way, I mean, half the world doesn't have access to the internet. And I think that this is one moment where we will trigger in making sure that there's enough investment in digital infrastructure, because that's where the future is headed. Secondly, I would say that in terms of the work from home, I want to stay optimistic that this might help with getting more women into the workforce, that this will give them the flexibility to manage home and work. And now we've realized that one can do this, and that flexibility, previously was there in some cases, it wasn't there. I think this has become much more acceptable now. So I wonder if that's going to be another important step. The third is, I think countries I'd like to say this accelerates the need and the desire to move towards a green economy, to make sure that you're mitigating the risks from climate change. We've seen already the outcomes of wildfires and floods and droughts and extreme weather that's already happening around the world. We have the Paris Agreement, but the current track on which countries are is just not enough to make sure that the planet is not overheating. And so I think my hope is that with this pandemic, that there will be this will trigger a shift towards making not just a more prosperous economy, but more sustainable in terms of inequality, but also in terms of greening the economy.
Thank you, Rita. Is there any uplifting final remarks on whether there will be something good coming out of this?
Yeah, I've already mentioned, I think there could be a change in attitude toward redistribution, and this was emphasized both by Jonathan and Gita. And then I want to maybe end on the climate change idea. I think it's been very, very difficult for us as humans to project ourselves into a future that is not the one we have today. And in particular, this pandemic was warned. It's not that we didn't know that it was going to happen. This was many people had told us this is just going to happen one day or the other. And yet, as late as February, at least it was not, in everybody's mind, certainly not in mine at that point. And I think it's a little bit the same for climate change, that the science is very clear. We are being warned, and yet for many people, it's not in their consciousness. And I think this pandemic is doing two things for us. First of all, it tells us that sometimes, just sometimes, science is real. And what scientists tell us, it happens. And sometimes nature is stronger than us. And I think it's not bad maybe to have a dress rehearsal of some sort. For something that we are lucky to be able to deal with the vaccine, maybe. Climate change is not going to be addressed with a vaccine, so we have to put in place the conditions that it's not as bad and to mitigate it today. So that's the first way in which the pandemic might help as a wake-up call. And I think, for example, France had municipal election right after the first lockdown, and there was a huge surge in vote for the Green Party, which I think is a reflection of that. The second way in which it can helpful to fight climate change is that we're realizing that the way that we are used to consume and interact with each other, and we can actually change when we have to. So I think people don't love to work from home or to be locked down. I don't. But there are other things that we realize we can do. For example, take our bicycles to commute to work. Paris has transformed into a gigantic cycle path with the pandemic, and we are not going back. That's a small example, but I think one of that human beings are creatures of habits. I think if we're seeing that we can consume and live slightly differently, and it's not that bad in some ways, some aspect of it's not that bad, then we can start to incorporate this change in attitude and behavior into our day-to-day lives, which is going to be necessary if we want to make progress against climate change.
That's a wonderful note to end. I think first, science matters, and second, we can change. So thank you so much to our three panelists for a really engaging, very interesting discussion, I think, for everyone. We are now going into our second break of the symposium, and we will be showing a short video with Professor Ferguson in conversation with Mr. Tony Blair, Executive Chairman of the Tony Blair Institute for Global Change and the former Prime Minister of the UK. And the event will resume with pandemic preparedness following this video. Thank you very much.
It's a great pleasure to mark the first anniversary of the Abdul Latif Jameel Institute for Disease and Emergency Analytics with a discussion with Tony Blair, who needs no introduction, but has been the longest serving Labour Prime Minister to date and pre-election time winner, and now heads the Tony Blair Institute for Global Change. Tony, it's a pleasure to be here today.
Thanks, Neil. Thanks to you and all the work that's being done by the Jameel Institute as well. It's a great organisation.
Thank you. It's been an unprecedented year for us all. I couldn't have imagined being where I am now a year ago. What was most surprising, unexpected for you?
The most surprising thing for me has been the absence of global coordination and political leadership on what is an unprecedented crisis, the biggest challenge that government has ever faced. And it's been completely global. In other words, all countries face basically the same problem with their own context and circumstances, but essentially the same problem. How do you cut down the disease, control it, or eradicate it? And yet the global leadership that you would expect in such a situation has just not been present. And if it had been, I think we would have all got through this a lot quicker.
Yes, and it's a paradox that scientifically there has been immense coordination. I was on a call this weekend with many scientific leaders across Europe, but it hasn't materialized in a political sense. And so where do you think we are now? I mean, from an economic and political perspective, how do you see the next 6 months unfolding?
I think there are some big decisions that we need to take pretty fast. I think there's going to be a major question as to whether we get vaccines and therapeutics out of the door quicker. I still think without mass testing, it's hard to get a handle on the disease. And we have had in recent times the development of much more accurate rapid tests. But I think getting to what I would say are the four elements of this that are necessary: vaccines, therapeutics, testing, and then the other thing, which is data, having the ability to track what's happening and assemble, real-time data. Those are the big challenges, I think. And if we rise to those challenges, then I think there is light at the end of the tunnel and we can get through this. But if we don't, then the economic damage of a further heavy lockdown, if it takes us till spring or summer next year to really get on top of this, then I think we're going to face an unprecedented economic situation.
Yes, I'm struck, and you must find this in your conversations, by how similar, at least across Europe, the challenges being faced by politicians, by communities are.
Yeah, and it's one of the things that you realize about this type of situation in government is you've got to get really organized. And one of the hardest things is not taking the decision, but actually identifying what the decision is. And then I think there's been an inability on the part of political leaders to distinguish where science ends and judgment begins. Political leaders are finding it hard to establish the right risk calculus. So, it's not a question of the economy or health. You've got to balance the two, because there are also other health aspects to lockdown, but also, and in addition to that, apply a consistent risk calculus. So in some areas we're applying zero risk, and in other areas we're saying, well, we'll take quite considerable risk. But again, for governments, this is such a difficult question, because it's always in the nature of bureaucratic systems to be somewhat small c conservative in the actions they take, because you will always get punished as a government for acts of commission, but acts of omission tend to get less punished.
And I think understanding exponentially growing risk is a challenge in many policy circles. I see at the moment a trade-off between being played out in the media and the political discourse of, is it society or is it health? But the fact is, if we allow case numbers to rise ever more, the health service in any country will not be able to cope with the pressures.
That's absolutely right. And in addition, by the way, if the case numbers rise in a huge way, and so people find a second wave like the first wave, then quite apart from whatever the government says, people won't have confidence. And if they don't have confidence, of course, that has a huge economic and health impact.
I agree. It's going to be a very difficult few months. And I think clear communication and having a strategy and objectives you're wanting to meet would help a lot. And I think it's not a criticism of this government, but I see across Europe, across the world, very reactive policy making.
I think that the two big challenges, along with all the others, but which are less obvious, is one, I think you've got to have a plan. And the reason for having a plan is because it's a good idea in itself, but also because if you're communicating to people exactly what it all means and you're explaining, this is where government as an explainer is such an important dimension. And you will give people confidence if they feel there is a plan that you are working to. And the other thing is that you've got to make sure that the things that you're asking people to do are consistent with each other. I mean, if people feel that the rules don't make sense, then your compliance drops. And one of the huge problems we have in the UK is compliance has dropped. I think one other issue which is very difficult is the degree to which, and I think politicians find this very challenging, how far are the public prepared to go in accepting quite tough surveillance in order to get on top of the disease? Because if you look at a country like South Korea, they have taken some measures on surveillance pretty close to what they did in China. In other words, very, very tough measures. Now, South Korea is a democracy, China isn't. But the point is, it was essential for them to get on top of the disease that this surveillance was put in place. And we prepared to do that. Now, I think, personally, I think the public's prepared for some quite draconian measures if they see it's according to a plan and it actually can work.
So looking further forward, I mean, what do you think are going to be some of the longer term challenges and perhaps opportunities? Because this is the biggest economic shock the world has seen since the Second World War. And as you well know, low-income countries have been far worse affected than high-income countries.
Yeah, so it is a bit like a war in several senses, but here's one sense that I think is interesting. What happens when you get a crisis that is so dominant, in particular global crisis like this, is that everything that was there before the crisis is there afterwards, but accelerated and intensified. Therefore, what you're going to find is that many of the social concerns, inequality, income stagnation, the wealthy are getting wealthier, the poor are getting poorer idea, I think you're going to find all of those things back, but with a vengeance and very, very strong. And that's going to pose a real challenge to policymakers in a constrained fiscal environment. And then a whole lot of things that people did during lockdown or started during lockdown, like remote working, some of that is going to continue even after COVID ends. And I think one big thing, which is a challenge and an opportunity, is that the adoption of technology is going to be accelerated. In other words, people have learned during the course of this crisis that with technology we can do a lot and we can do it differently. And that is going to be a challenge because it will mean some jobs get displaced, but it's going to be an opportunity because following this, at least in the sphere of global health and disease, all of those things that we were doing in a slow and incoherent way before the crisis, we should be doing in a rapid and cohesive way afterwards.
It brings me to my final question. How do you think, data science, analytics, what we do in JIDEA can contribute to that?
I think data is absolutely key. It's one of the things I've learned during the course of this crisis. And that's why what you're doing at the Jameel Institute is so important. With good data and using good data well, the capability of that is absolutely transformative.
Yes, and we can see that in terms of how people are just tracking this epidemic day by day and around the world. It has been truly remarkable compared with anything I've experienced before.
Yeah, and one of the important things about your institute, but also other similar types of initiative, and there'll be more to come, I'm sure, afterwards, is if we did this on a globally coordinated basis, think how much better we'd be. For the UK, given we have a national health service, for us it should be relatively simple to collect the data and extremely valuable for the country.
Yeah. Thank you, Tony.
Thanks very much, Neil.
Great to chat, and feel free to reach out anytime. Thank you.
Thanks very much. All the very best. Look after yourself.
Okay, I think we're back live, and I'm happy to be facilitating this final session. My name is Tim Hallett. I'm a professor here at Imperial College and investigator at JIDEA. I'd just like to remind you of some of the housekeeping issues that you have heard before. So there was this is all being recorded, so any contributions you make in the chat with your name would be recorded. Please do put your questions in the Q&A box. It's really exciting seeing all those questions come up as the session goes on, and I'll be trying to put as many as I can to the panelists at the end. Apparently, it's also possible to upvote questions that are of particular interest to you. So do that, and I'll make sure that I come to those which are most voted. So this session is about the next pandemic in a way. The first session was about this current pandemic that we're in. The second session began to talk about how we move out of this pandemic and the scarring, as I heard it be called, it being measured. And this session is about the next pandemic. We've got three really exciting speakers, and I'll introduce each in turn, go to them for their comments, and then we'll have a discussion all together after each of them has spoken. The first speaker is Dame Sally Davies. So she is the Master of Trinity College, Cambridge. Before this, though, she was the Chief Medical Officer for England and Chief Medical Advisor to the UK government from March 2011 to September 2019, having held the post on an interim basis since June 2010. Dame Sally has spoken on antimicrobial resistance at numerous global events, including the World Health Assembly side event, the G8 Science Ministers meeting in 2015, the Global Health Security Initiative, and the UN General Assembly side event. For 3 years, she was the chair of the WHO Strategic and Technical Advisory Group on AMR, and Dame Sally was a member of the World Health Organization Executive Board 2014-2016, and led delegations to a range of WHO summits and fora since 2004. With that, Dame Sally, may I hand over to you for your initial comments?
Thank you very much, Tim. I hope you can hear me well. Of course, I'm honoured to be here to participate in this J-IDEA symposium hosted by Imperial, of which actually I'm an emeritus fellow. And today I'm joined by two other panellists. John, I'm particularly inspired by the work of Africa CDC and how you've just launched the new $100 million Africa Pathogen Genomics Initiative to improve disease surveillance and emergency response in Africa. You're doing lots of multi-sectoral work, and it's just what we need to prepare to go forward. And Peter Smith and I have known each other for years. He is always sage and great on the health economics of issues. So panelists so far have spoken to you about what we know about COVID-19 and its impact. And I want to talk about what we can learn from COVID-19, especially in terms of analytics, a topic at the centre of J-IDEA's mission. As this second wave comes through many countries around the globe, we're facing a chilling reality. And yes, vaccines, if they're effective and safe, will change this, but we're still in the middle of a dreadful period. And we have to remember that COVID-19 is neither the first nor the last health emergency we're going to face. Scientists estimate that we face a health emergency or pandemic at least once every 5 years from here on. And of course, we've got this big, slow pandemic happening as we speak of antimicrobial resistance rising up and already killing at least 700,000 a year. So recognizing all of this, we can and we must say never again like COVID-19. We can and must do better to identify the next health threats as well as respond to COVID-19 and AMR. We've got to respond to those threats before they become an epidemic or a pandemic. And if it does become that, recover in a way that does not exacerbate health, economic and social inequalities. So how do we do better? Well, as we've been saying at this meeting all day, doing better is in analytics and data, as this institute testifies. COVID-19's highlighted the pervasive weaknesses in data sharing systems. Among the lessons to be gleaned, there are three clear findings, we believe, across the private, public and social sectors. We, the actors in all sectors, are inefficient in getting the right people, the right access to the right data at the right time. We are ineffective in combining insights gained across data sources and sectors. So as a consequence, our use of data and information to make fact-based decisions and improve outcomes calls for more efficiency and effectiveness. Everyone, and by that I mean not just public and social sector leaders, but also the private sector and government, needs to take immediate action to remedy this. We've got to accelerate efforts to make better use of publicly available data. We've got to strive to increase the breadth and depth of access to non-health data, generally held by private firms, often about behaviour, movement, consumption, spending. And we must bring data providers, analysts, researchers and decision makers into closer collaboration. So how do we start to do this better? Well, one way we are bringing people together for the better is through the Trinity Challenge, a coalition of which I'm very proud to have assembled. Our founding members are committed now, not waiting for the next pandemic to take us by surprise. We, the Trinity Challenge, are a partnership of 22 founding members who span leaders in academia, including Imperial, hosting the symposium today, Hong Kong University Medical School, technology companies like Google, Facebook, Tencent, and the private sector like GSK, Optum, McKinsey. It's a recognition by business, academia, and philanthropy for the need for new breakthrough ideas and approaches to change behaviours to learn and beat future pandemics. It's also a recognition that, to support preparedness, the first step is to understand that the solutions we need can come from anywhere and anyone. So our Trinity Challenge helps us to turn aspirations into reality, and we're focused on 3 core activities. Launching a new global challenge, look at our website, thetrinitychallenge.org, facilitating a unique collaborations generally across members, and we've got wonderful examples. And finally, strengthening data analytics and learning ecosystem by contributing thought leadership, for example, with the report I've just mentioned. The path towards better preparedness, response and recovery is not going to be a straightforward one, and it's conversations across countries and sectors like this one organised by J-IDEA today that will allow us to collaborate better along the way. Work of all those in the global health community attending today and that of my fellow panellists is critical. We've got to say never again to COVID-19 and other pandemics. We've got to sort out AMR, and we'll have to do it together. So finally, I want to thank the Abdul Latif Jameel Institute for organising this event to bring us together today, in particular, Mohammed Jameel, founder of Community Jameel, for his commitment to community support, especially in the areas of global health for vulnerable people. It's a pleasure to be here. I look forward to our discussion. Thank you.
Thank you very much. Really important remarks. I'll move on to our next panelist, who I'm delighted to say is Dr. John Lukengasong, who is currently serving as the Director of the African Centres for Disease Control and Prevention. Early this year, he was also appointed as one of the WHO Director General's special envoys on COVID-19 preparedness and response. Prior to his current position, he has served as the acting Deputy Principal Director of the Centre for Global Health at the United States Centers for Disease Control and Prevention. Dr. Lukengasong has received numerous awards for his work, including the Shepherd Award, the William Watson Medal of Excellence, and which is the highest recognition awarded by CDC. He is also the recipient of the Knight of Honour Medal by the government of Côte d'Ivoire, was knighted in 2017 as the Officer of Loin by the President of Senegal, and knighted in November 2018 by the government of Cameroon for his significant contribution to public health. He serves on several international advisory boards, including that of CEPI, we've already heard about a lot today, and the International AIDS Vaccine Initiative, IAVI. Dr. Lukengasong, please may I hand over to you for your initial remarks.
Thank you. Let me first of all start by thanking organizers for including me as part of this conversation. I think it's hard to follow through what Sally Davids mentioned. I think it's always a pleasure, Sally, to be on the panel with you. And of course, Peter, I'm really looking forward to a very stimulating conversation. So just to reflect on the title, which says, how can we better prepare for pandemics? I think a couple of reflections, I think three of them. One is that this pandemic is unprecedented, but it's predictable. We all met after the Ebola crisis and talked about the need to have a global health security. We all talked about the day that a pandemic will be here, and here today, and this year we have a pandemic. So the key question becomes, what do we do to prepare for pandemics? And it's not like we don't know. We know what we have to do. I mean, and after the Ebola crisis in West Africa, many reports were written, many assessments were done, and the reports were published in prestigious journals like the New England, the Lancet, the UN has a report, the World Bank has a report. So we ask ourselves the question, why did we not act on those reports? I think that is important. And I'm very convinced that other reports are being prepared now as to describe the after action items of and lessons learned from COVID-19. The truth is that we truly didn't learn a lot from Ebola, the Ebola crisis in West Africa. You only learn a lesson if you do something with those lessons. I think if otherwise, what we did was documenting our experience, that what we saw in West Africa. And so that requires that we truly engage ourselves in a behavior change mindset, a behavioral change mindset that speaks to a new architecture that will govern us as we prepare for pandemics. I mean, we will be living we live in an age of pandemics. Let that be very clear. And I'm sure that Sally, when she used the word "never again" twice, and I'm sure that after this crisis, we are going to say never again would another virus challenge us for this long. And we said that during the Ebola outbreak in West Africa, that never again would we be in that situation. So we really didn't learn a lot from West Africa, the outbreak there. So we need to do three things. And first of all is that we need to embrace a new governance, pandemic governance structure, which is divided into three layers. One is a very strong WHO. We have to empower WHO, strengthen it, but very importantly, empower it. I mean, and I underline the word empower. We know that we have the instruments. The international health regulations are tools that we all agreed on, but the implementation has been lousy. I think if only we implemented 60 to 70% of that, we will prepare ourselves better for the next pandemic. I think one is an empowered WHO, a strengthened WHO. Second is we have to begin to regionalize that. We cannot, you cannot ensure the health security of the whole continent by having a centralized mechanism and which controls how we fight pandemics. I think we make it vulnerable. And that's why we blame WHO in 2014, and the WHO is being blamed now. We cannot continue to blame ourselves out of these pandemics. It doesn't work. So it means we have to strengthen regional structures that will complement the work of WHO. Regional structures like PAHO, regional structures like the Africa CDC, that will complement the work that WHO does. And lastly is that we need to look at it nationally, that health security or global health security starts with national health security. Without national health security at the local level, we cannot achieve global health security, and we cannot fight pandemics. I think that is very important. And we look at it in three key areas. One is that workforce development has to be a very deliberate process. We have to ask ourselves the questions and address them, and in a way that and provoke ourselves in a way that the discussions are uncomfortable and the discussions are bold. Ask ourselves the question: a continent like Africa needs 6,000 epidemiologists. We only currently have 1,900. How do we move from 1,900 to 6,000 in a very deliberate manner? And other workers that we need. for public health. Second is really local and regional manufacturing of diagnostics and therapeutics and personal protective equipment. We also learned, all of us, that China has been in quote unquote the kitchen that produces everything that we need. I mean, that kitchen has to be diversified so that each region has the ability to produce those personal protective equipment, diagnostics, and vaccines. If you look at the vaccine headlines now, and you compare that with the H1N1 vaccine story that we all witnessed in 2009, you think you are in 2009. I mean, if you remember, but we are in 2020. I mean, the same highlights and headlines made it that we read in 2009 are today. I mean, the West is all going to buy the vaccines. Country X is going to take all the vaccines, or developing worlds are not going to have the vaccines. That was in 2009. 2020, we are still discussing that. So we need a way, as people living on the same planet, to organize ourselves and have a global pandemic arrangement that diminishes that kind of a conversation and dialogue. And I think I'll end there, at least for my introductory remarks, and I look forward to a lively conversation.
Thank you very much. Yeah, I think that really tees up lots of future questions that we'll be getting into all together. Thank you again. Let me now introduce our third panelist, who is Professor Peter Smith. Professor Smith is Emeritus Professor of Health Policy at Imperial College and a Professor of Global Health Economics at the University of York. Originally trained as a mathematician, his main research interests are in the economics of health systems, with a special emphasis on the link between research evidence and policy. Together with colleagues, he has published widely on these and related topics, including over 170 reference papers, 14 books as an author or editor. Professor Smith has acted in numerous UK governmental advisory capacities and has also advised many overseas governments and international agencies, including the World Health Organization, the IMF and the World Bank, the Inter-American Development Bank, the Global Fund, the European Commission, and the Organization for Economic Cooperation and Development. Thank you very much for being here, Peter Smith. Can I hand over to you for your initial comments, please?
Thank you very much, Tim. And thank you to the organisers for this very kind invitation to join you. And I'm very humble to be speaking after such distinguished speakers in this panel and indeed beforehand. And indeed, many of the issues I was going to talk about have in fact been raised already. And so what I plan to do is just try and put them in the context of a framework with some ideas about the implications for researchers. I'd first like to go back to 2009 when I was at speaking at the World Economic Forum, and this meeting was full of politicians and bankers and finance experts bemoaning the consequences of the 2008 financial crash. And a colleague and I stood up from the audience and said, well, we'd done a back of the envelope calculation, which indicated that just the most rudimentary calculations would suggest that a pandemic would dwarf the impact of that 2008 financial crash. And we were treated with very short shrift at that meeting. That's not going to happen. That's basically the story. Of course, history has shown otherwise. But what does this tell us about the need for preparedness? What has our experience told us? I think there are broadly 5 areas that we need to look at in preparing for a future pandemic. The first is, what services do we need to actually be prepared, such as surveillance, creation of information, and delivery of services such as vaccination. So this is one of the key issues here is that most of these services cannot be delivered by a market. They are what economists call public goods. WHO, in a very interesting initiative in which I was involved last year, describes them as common goods for health. They have to be financed, produced by the public sector or some equivalent. Secondly, what is the institutional structure to provide these services, and who are those institutions accountable to? We can often say what needs to be done, but how is it going to be arranged, and who's going to be responsible for doing it? And John's already mentioned, this mix of local, national, and global institutions that are needed to make the preparedness happen. Third issue is the governance arrangements to assure that all these institutions do their job effectively. And here we've really fallen down in advance of the COVID epidemic. It was clear that many countries nominally had arrangements in place, but actually, when it came to the crunch, they didn't work very well. Fourthly, what is the finance needed to provide these services, and what are the incentives that will be put in place to make sure that it happens? I mentioned earlier that these are almost certainly going to be based on some sort of communal funding, of course, taxation in many countries, philanthropy in others, development aid in poorer countries. And it's essential that the amounts involved are probably relatively small compared to many of the other aspects of health systems, but it does seem to be really difficult to assure that funding. And finally, the fifth need is to understand the response of populations to any pandemic, to understand responses to disinformation, how they can be countered, and how they respond to the various incentives and information put in front of them. So what are the implications of all this for researchers? I've picked out, again, 5 implications. First of all, researchers need to understand the decision maker's perspective. They need to understand the limits, the objectives, the constraints that are operating on decision makers, and to recognize that they are often highly constrained in the way that they can make decisions, and that a solution has to be framed within the context of that decision-making perspective. Secondly, and that this has come through over and over again, the need for a multidisciplinary perspective on the pandemic. Of course, epidemiology has to be at the centre, and I too have been bowled over by the excellence of the epidemiological work. But that has to be augmented and put alongside the work of other disciplines such as economists, psychologists, anthropologists, political scientists, statisticians, operational researchers, and so on and so on. These all have important contributions to make to producing optimal solutions. Third issue, I think Jeremy this morning said this, is the speed and salience with which evidence is produced. Sometimes speed has to be prime, but also it's important that researchers don't do that bit of extra refinement which will never change a decision. They recognize the value of refinement and the delay that it implies. Fourthly, Tony Blair had mentioned this in his interview, so I'm in good company for once. He suggested that, or said it's really important to keep the science and the values separate. And actually in my own country, in UK, these are constantly being mixed up with the objective science being mixed up with personal values. And finally, we should never lose sight of the importance of looking at the distribution of outcomes between different population groups, the whole equality issue, because this is often of fundamental importance, and it's also a key issue for many decision makers. So, in conclusion, COVID should forever have dispelled the skepticism that we encountered 10 years ago of the economic dangers of pandemics. So it's certainly pushed it right to the top of the agenda for the foreseeable future. And so it's a huge opportunity to make a step change in public health preparedness. In research, this should stimulate a major step towards genuinely multidisciplinary perspectives. And in that respect, I hope this will become a major role for the Jameel community and specifically the JID. Thank you very much, Tim.
Thank you very much. Okay, well, we've set the table now, and each of the panelists has put forward their initial remarks. So I'd like to just, if I may, put an initial comment to each of you to begin with, which I've directed at someone. But other panelists do feel free to chip in afterwards if you'd like to. So James, Sally, if I can come to you first. Now, I mean, we're all struck that, of course, you would have been the one contributing a lot to preparedness for a future pandemic. And then, as Professor Duflo said, sometimes science is real, and here we are. So I wonder if you could just reflect on the extent to which all of that planning has, in fact, helped, or at least helped shape what we see today in the UK.
Thank you. What a difficult question, because what we can see is the planning and the work about scientific advice has worked, and the NHS has responded wonderfully. What I don't think we took account of, and we're going to have to think through very carefully, is the impact of the pandemic, in this case COVID, on different groups in society. And we know that in Britain we have some of the highest levels of obesity, diabetes, and chronic diseases, but particularly the ones based around overweight in our comparator countries. And those plus other inequalities have clearly impacted dramatically. And we're going to have to think about this quite differently going forwards. So I think that that's important. I also think that we have been very limited about how we've been able to use data. And one of the mental exercises I've been going through is thinking, what do I wish we'd done 5 years ago? And I come back to data. But actually what we can do now, looking forward, which is why we set up the Trinity Challenge, is quite different. We can access data that the big platform companies are collecting. We can do machine learning, natural language processing, AI in ways that we couldn't do before. So I think looking forwards, we need to make sure that we bring in all these very different ways. And I hope that we bring them into antimicrobial resistance as well, because as I said, that's the slow rising pandemic that we know is killing a terrific number of people.
Thank you. Sure, we'll come back to those, that theme of AMR. Can I just put the same question to Dr. Nukangasong, actually? You were involved in preparing for pandemics. You talked about lessons not having been learnt from Ebola, but how did those plans shape what we see playing out today?
So, I mean, thank you. I think we have, for the continent of Africa, we have benefited from the past experiences in fighting Ebola, the past experiences in the borrowing from HIV, AIDS pandemic. We should never forget that we still have an HIV pandemic going on on the continent that kills about 500,000 people a year. And to deploy that in very unique ways. For example, the community engagement. I mean, the community has played a very central role in this, in a fight against this pandemic, we have deployed actually about 10,000 community workers in several member states. I think those are lessons we learned from before. The more than 200 people that we've deployed across the continent in terms of responders, these are epidemiologists and others, are those that were brought together during the Ebola crisis and as part of what we call the African Health Workforce Development that was deployed during the Ebola in West Africa. So I think some national public health institutions, i.e. the Nigeria CDC, the Liberia National Public Health Institute, Sierra Leone National Public Health Institute, were all the creations after that, but not at scale. I mean, they were still very limited. As a continent of 55 member states, 1.2 billion people, we currently have about 16 countries that have anything that are characterized as a functional national public health institute. And you can see clearly that during this pandemic, those organizations, i.e. what Chikwe has done in Nigeria with the Nigeria CDC, is outstanding. And other countries without such structures have suffered, I mean, a lot. So I think it's very clear that we really step back and focus on what I call or characterize as the known do-nothing gaps, and to prepare for the next pandemic. We know what those gaps are. I mean, and they have been there. And it's just that we don't focus on them in a deliberate manner. We tend to talk about it more than we're actually committing our own efforts to that in terms of funding, in terms of being consistent and not letting politics influence it. I think it should really be like a war we are fighting, and it is a war we are fighting. And you don't fight a war by doing it when you want, and then the other day the enemy attacks. You do that in a very deliberate fashion. I think we should learn from the military how they prepare for war, so that we can use those lessons to prepare for the next pandemic.
Yeah, that's really interesting. Okay, I think that actually brings me to the question I wanted to put to Professor Smith as he was speaking. So, I mean, what we've been saying is that throughout the day, we've been speaking with a certain amount of assuredness, it seems to me. Oh, we know that these things are going to happen every 5 to 10 years. Your back of the envelope calculation, Peter, shows it's an incredible return on investment. But of course, these things aren't certain and they aren't totally clear. And what to do is not totally clear either. So I don't think we should fall into the trap of having that false sense of security. But so that's my question to you, Peter. How, given the uncertainty, how do we articulate sort of the business case, the investment case for preparedness, and precisely how high should it be on the list of priorities? And I'm thinking particularly of low-income countries whose health systems are already so stretched and having to deal with so much.
Yeah, I mean, if I could just sort of preface my answer by just mentioning the difficulties that that preparedness has in going up to the top of the agenda. The sort of political economy, if you like, of preparedness, because it always seems to be recognised as important, but a low priority for immediate action. And I think the first reason is that if you have a choice of investing in, let's say, a new surveillance system for diseases that may occur sometime in the future, and personal health services, such as maternal care and so on, that may be a false dichotomy, but in the end, that sort of choice is being made. Then I'm afraid most politicians would almost certainly feel that the second is the priority in many circumstances, even though in terms of years of life saved and so on, the preparedness is a better investment. Secondly, it's a huge effort to establish many of these surveillance and information systems that we might be talking about as being elements of preparedness. But then they tend to get neglected once they're established. So that different skills are needed from the establishment of these institutions to then making sure they continue to function effectively. And I think that's a major issue of accountability and measuring continued effectiveness. And finally, countries, could be hoping to be able to free ride on others because these are common goods or public goods. They may feel they can free ride. So for all of those reasons, I think it's really difficult for very hard-pressed countries to find the funding and the political priority to invest in preparedness. That's why I think in many countries, this to me seems to be a major priority for international donor aid and maybe moving away from the vertical programs of direct single disease contributions towards funding preparedness. And I know that's difficult for funders because it's not really very sexy to be able to say, you're funding a public health surveillance system, but actually they are so important and they're so difficult to fund locally that I think I would really urge funders to try and be able to go in that direction.
It's interesting. I want to just pick up, if I may, on the issue of data that's come up. So Dame Sally Davies has been talking about, what would we do if we had more data? And it's heartening to hear that, because as an analyst and modeler myself, I'm often the one asking for more data and being told that what I've got is plenty good enough. Thank you very much. So I wonder if Dr. Nkangasong, you actually are thinking the same thing in the context of Africa CDC. Are there particular pieces of data, streams of data that you would like to have, that you would find very valuable now, that would be helping guide your response, and what are they? And is there anything that can be done to ensure they happen in the future? And then I'll come to Dame Sally with a particular question for the UK in follow-up, if I may, as well. So, Dr. Nkangasong.
No, thank you. I think data should be seen as that cross-cutting element that we must have in place, and to support our next pandemic or the existing endemic diseases, I think in a cross-cutting manner. So that means that we have to start off by developing an architecture for data that suits a region or a continent like Africa. And that means we have to look at it in several dimensions. One is data, what I call data acquisition. And then second is data storage. And the third is data sharing. And then fourthly is data use. I mean, if you have to have a good data architecture to prepare us for the next pandemic, you have to have these four elements in place. And we do that in a very purposeful manner. And so, to be very specific, if you ask me the question today, what is the most urgent data set that I need for the continent, is I would like to see more data on mortality surveillance, generated from mortality surveillance on the continent, in terms of to measure the impact of COVID and who has died and who has died because of COVID, so that we can at least begin to look at those excess deaths that are very, very important. Before COVID, we as Africa CDC, we had a mantra where we say that we need to count everybody on the continent and make anybody on the continent count. And then I think I still hold that true. That was the before COVID, and we still have to be sure that we push through with that mantra. But place the mantra squarely on those four elements that I just mentioned, i.e. quality data acquisition, storage of that data, or archiving, sharing it across the continent, and then use it in a timely manner. I really underline timely manner.
Yeah, no, thank you. I think, yeah, sharing and timely sound like absolutely key words in that. And that echoes what Dame Sally was saying at the beginning. So I wanted to say to you, Dame Sally, so you're identifying these gaps, and I want to understand a little bit more about how you think those gaps, could be filled. and you mentioned the Trinity Challenge. Is that a big part of the solution or a small part? How does it all fit together in your mind?
Well, and what we're looking for through the Trinity Challenge are the breakthrough ideas that can be scaled and used by others. So it's data for action. But I liked John's way of talking about 4 elements. Just let's think, what do you need data for, which is what he was saying. So you need data to understand, have you got the PPE you need? Where is it? What are you doing? That's for logistics. That's one sort of data. And the health and social care systems need that. But it's also needed in meat packing plants and many other places. How about data about movement? Why would we be interested in that? Well, we've already seen people learning by using movement data from Google and others that you can begin to understand what people are doing. Are they going on transport? Are they going to restaurants and pubs? Are they going to schools? Are they going to different homes? And then look at outcomes and how diseases are progressing. And that begins to tell you where danger spots for catching it are. That sort of data gives us information to act on. We didn't have that in the past, but now, as a gift from a number of companies, we can have that. What about the project that's a Trinity Challenge project that's ongoing? The Institute of Health Metrics and Evaluation, working with Oxford University, the Blavatnik, and with Microsoft, are assembling a database anyone can use, which tells you what the government mandate is at any time. You can begin to associate the mandate, masks, stay at home, whatever, with the outcomes, hospital admissions, deaths. Of course, you do have to have those. I absolutely agree with John. But then you can also put into that the Facebook survey work. Facebook are also one of our founding partners, and pick up in areas what people say they're actually doing. So you've got the mandate, what they say they're doing, and the outcomes, and begin again to see how those impact and what's going on. So I think we need data for many different reasons. The state or the health system does not hold all the data we need, and that's why we need to be able to bring it together to answer questions. I don't see the Trinity Challenge becoming a big data lake, though one of our partners, Swiss Re, does have a wonderful data lake if people want to use it for the Trinity Challenge challenges, including S&P data and soon some much more social data. But it is looking to find ways that you can find information that's actionable, so we can say for the future, if you have this data, you can learn this in this way.
Thank you. Okay, well, let me move now to questions that have come up in the Q&A box. And so we've gone from data and that informing responses and providing feedback and it all being truthful. There's a question come up from a member of the audience called Giles, who says that one critical issue has been dialogue with the public and the issue of what's been termed the infodemic, misinformation percolating and spreading. Maybe going forward, is there a way in which we can do better with communication between scientists and the public? This is open to whoever would like to jump in.
Maybe I should.
Dr. Nikingasong, why don't you start?
Yeah, maybe I should jump in and create a mess so that Sally and Peter can come clean the mess later on. I mean, I think we should admit that we live in a different era now, that scientists, we have to also embrace, move from our laboratories, where traditionally we have always believed that the best way to share our data is through a peer-reviewed journal and published with a high impact factor. I think we are talking amongst ourselves. I mean, and we used to do that because the outlets were very limited, and there was no social media and other channels there. But social media is there because that is what is fueling the misinformation. That the infodemics is that I mean, so until we recognize that it is there, until we recognize that we are not going to wish it away, I mean, we continue to be in trouble. I think that is very, very clear. We have to devise a system where we respect what our peer review process is, but when we also say, if I'm investigating vaccines in the lab and I see something that is coming out good, how do I put that story out there in a way that the social media can consume it and use it before we go through a peer review process, publish it in Nature, Lancet, Science, and for everybody to be happy with that. I think that much, I mean, we are behind. I mean, we should have to acknowledge that. Second thing is that how we communicate with we tap on social media to engage the community. The currency for good community engagement is truthfulness, is timely information, and is accuracy of information. If we have timely information, accurate information, and truthful information, then you can engage with the community. But if the community has, for any reason, doubts that we are not giving them information in a timely manner, we create a gap. And that gap must be filled by something. And with these gadgets that we all have in our hands, I mean, somebody will put out something there. And unfortunately, the propensity for the community to consume wrong information is so amazing. I think it's that we should factor that into what we do. And that brings me to the last point. That means that our work as public health experts can no longer be strictly in public health. We have to use a multidisciplinary approach, which means if we are going to go to country X or region X to fight these diseases, we have to have behavioral scientists with us. We have to have people who understand how to engage with the community and get them there. Otherwise, we find ourselves in this whole concept of the value of death, where you have the products and you can't use it actually in the community. We just completed a survey on the continent on vaccine perception amongst 10 countries, and we still have 5 to go. And about the range, the people that are willing to accept that will range from 60 to 80%, not 100%. I think, and I think that is some homework there ahead of us to do. It looks even better than in some developed countries, but I think it's not good enough for us if we have to flush this virus out of the continent. So I think we have some work ahead of us to do to catch up with engagement with the community.
Okay, thank you. Peter, were you going to come in as well on that question?
Well, actually, John has really much more wisely than I could ever say has said much of it. Maybe I could just add a couple of issues. One is that I think misinformation and misinterpretation takes a number of forms. And you can have at one extreme the complete skeptics who it seems can never be persuaded. But probably a much larger group will tend to be the uncertain, the worried, and so on. And I think there's the way to tackle those two groups is completely different. And so, for example, if people are worried about the uncertainty, then there are people like David Spiegelhalter who have shown. This is a colleague of yours, Sally, at Cambridge, I'm sure you know, who have shown how it's possible to really put very complex aspects of uncertainty in front of the general population so that they can be understood clearly. And I think there's a big role for that sort of work, not just in statistics, which is his discipline, but of course in epidemiology, economics, and so on. So I think that, and of course, as John says, we've got to involve sociologists, psychologists, behavioural scientists in all this as well. But I do think we need to recognise, as I say, the different types of misinformation, the different types of uncertainty, and not just try and have a blanket approach towards overcoming this problem. And there's a big research agenda there, of course.
Dame Sally, to you as well now.
So I thought John put it very well. I wanted to add one to his lists of truth and timely and topical. I wanted to add trust, which he and I do agree about. How do you use people, how do people develop trust in them as a communicator, or do we find the people who are trusted? We've got a very interesting Trinity Challenge project going on between Facebook and an NGO. Oh dear, I've forgotten the name in it for a moment. Internews. And Internews work in 75 low-income countries where they have a lot of false news, trying to make sure that true news is got over in local languages. And they're working on how you can build trusted networks to pass truthful, timely, topical, and everything else information along. But we can never stop. And the other added point about our learning, we did learn quite a lot from Ebola. One of the things we learned quite early in Sierra Leone in 2013 was that you needed people who understood the community, the academic discipline of anthropology. It's all very well working out that Ebola is passed at funerals. That's the first building block of doing something about it. But actually, you need to understand the practices and who are the community elders that can help change that and how to work with them. And again, you need people that the community elders or the church elders agree with and trust in order to make those changes. And we learned that, and we need to continue to remember that alongside the behavioural science. But I absolutely agree the Spiegel-Holter type of risk communications is a very good way of working.
Okay.
Thank you.
Very good. Look, so another question's come up on the chat, which I'm going to go to, and it's from John Oldfield. And what he's asking is, how can the global WASH community, environmental health community, how can they contribute to, disease X prevention? And maybe it's actually a wider question, as we think about joined up health systems and health security in the way that Dr. Gast talked about, are there specific ways that we could think of that different sectors should be all pulling together to contribute to preparedness in the future? Would you like to start? I'll start with you, Dame Sally, as I came to you last time.
Well, if we're going to support low-income countries in their preparedness, you have to start with decent sanitation and running water, WASH. We need to help them develop strong health systems across their countries. UHC is kind of the term we're using these days, because how do you respond if you don't have a strong health system? And that includes the public health vaccination systems and everything. I am absolutely aware of this because of all of my work on antimicrobial resistance, and I spend quite a lot of time supporting the WASH community as the foundation of the system we need in every country. I would finish by saying one other thing, that I think it's very interesting that now perhaps one of the best surveillance ways of finding out what's going on with COVID-19 is by testing sewage. So it's not only that we need WASH to protect people, we need effective systems as ways to monitor populations, communities, and even institutions. Thank you.
Very good. Thank you very much. Dr. Nkangasong.
Yes, I think that that is a very interesting question, because those are, if you look at, we just published a paper in Cell where we look at the evolution of diseases in Africa since independence. And you look at cholera, for example, the reoccurrence, I think that you think should be of the past. You still see it happening all the time. And we're still dealing with the HIV/AIDS pandemic. We lived with it for 40 years, the TB, antimicrobial resistance. So I would think that answer that question broadly, that the best way to prepare for the future properly is to invest in the now adequately. So the now are those challenges that we are facing, the cholera outbreaks. If we can use basic sanitation to get rid of that, and then isn't that what we are using in fighting COVID now? We say wash your hands, and I'm really hoping that by washing our hands many more times and sanitizing it, we are going to decrease the level of cholera outbreaks. We are going to decrease the level of antimicrobial resistance, because I mean, if you are not sick with a bacterial infection, I mean, there's no point that you take an antibiotic. So you start by washing your hands clean. So I'm really hoping that the whole, when this is all over, that the whole culture of washing hands often will become a culture embedded across the low and middle income countries. I mean, after this meeting, I'm going to wash my hands because I've been touching my own desk, which I've been sitting for the whole day. But then, because it's now beginning to be ingrained into our mindsets that you have to wash your hands all the time. So I think that I fully agree that we have to prepare. The best way to prepare for this future is to invest in the now and do that appropriately.
Very good. Peter, Professor Smith?
Yeah, I hesitate to intervene after two such experts on this. Maybe I'll just say something rather more general about intersectoral collaboration. I've been working with people in Thailand on non-communicable diseases, but as part of that study, they did interviews with public health managers across that region. And one of the things they found was that these frontline public health managers had very little experience or confidence or knowledge of working with other sectors. And yet we know that so much of public health relies on the actions of other sectors like schools, housing, and employers and so on. So I think there's a big agenda there for the health systems to actually engage much more creatively and constructively with these other sectors, and to recognise that if they want those sectors to help create health, which is the role of the health system, then maybe they have to put some real finance into those other sectors to actually make sure that their actions are contributing to health along the lines that the health system wants. And I think that's a real big gap at the moment. It's not hard to envisage. I think the big challenge is getting the accountability arrangements in place so that the two sectors can work alongside each other and both feel that they're contributing each to their own agenda, but to a greater public good by the joint actions that they create.
Okay, well, thank you very much. Look, I think that brings us to the end of our session. Our time has run out. It has been recorded, so we can play this back on the occasion of the 10th birthday of the idea, and we can see how many of these ambitions we have for the future have been realised. Thank you very much to each of you, James Taylor Davis, Dr. John Gaston, Professor Peter Smith. It's been a tremendous privilege talking to you all. Thank you very much again. I'll now hand over to Professor Neil Ferguson for closing remarks.
Hi, and thank you, Tim. I remember earlier in the sessions, somebody talked about another pandemic in the next 10 years, and I strongly hope that we are not in that position, but we certainly need to prepare. I'm not going to try and summarize all those 3 sessions. I mean, they covered a huge amount of ground, but it's interesting some common resonances looking forward from some of them. I mean, particularly noticed the challenges of preparedness, and I thought highlighted in the last session, and the investment in preparedness, and how there are some parallels there with responding to climate change, which is another threat where the consequences are not completely, they're happening now, but are going to be even worse in the future. And how do you prioritize those sorts of investments for the future versus responding to urgent needs today? But I'd just like to finish by saying, I mean, it's been a very eventful year for all of us at JIDEA, and many, many thanks to all of our partners we work with and the funders, which are many, but particularly Community Jameel, and many thanks for the speakers and facilitators in this symposium. I hope everybody found it interesting. We will undoubtedly be doing another one in the next few months to look back more definitively on the pandemic and learn further lessons for the future. Thank you.